Good afternoon, Raviraj. We are there with endocrine bone and CNS. You've been commenting on every video. I'm going to ask you questions, Ravi, and you're going to answer throughout the video. Fine? Okay. Perfect. So let's start. So since you guys asked endocrine bone and CNS, primarily I'll start with one thing. These are not very hardcore pathology topic. Uh, yes, you might get a few questions with respect to pathology. You'll read lots of endocrine in medicine and surgery. Bone, you have an entire subject of orthopedics. You'll read more of them. CNS is something which, apart from the CNS medicine, stroke, and others, CNS tumors, it's not even that much important. So we'll definitely, as usual, cover the important topics for your university exams in the same model which you have covered before. Fine, perfect. With that note, let's start with endocrine. Again, first going before going to the question, I want you to tell I'm going to ask you a few questions. You're going to tell a few answers. Based on that, we'll take it forward. The most important thing in diagnosis of endocrine disorders, biochemical values, and understanding how the biochemistry works behind it. That's all, as simple as that. I'm sure in your physiology and biochemistry, you must have read about feedback mechanisms. That is very, very important. If a LAQ comes on thyroid function test, please don't look at T3, T4 value alone and answer the question. That's not how it should be answered, right? So the first and the most important thing is, how do I interpret thyroid function test? TFT alone can definitely come in a short answer as well, right? How do I interpret a thyroid function test? There are three things in thyroid function test. To be very simple, T3, T4 and TSH. There's a concept of free T3, free T4. You will learn that in medicine and surgery whenever you go to this. The golden rule of every thyroid function test is never interpret T3 and T4 in isolation. Now and the future. In future, when you go and start practicing, people will give you only T3, T4 values. They are cheaper. TSH might not be there. Please do not interpret them, because TSH determines where the problem could be, at least a diagnosis, right? So if I have an elevated T3, T4, definitely is hyperthyroidism, but TSH is very, very important. Normally, when T3 and T4 elevates, can you guys tell me what will happen to TSH? Normally, I'm not talking about in terms of disease. Normally, when the T3, T4 gets elevated, what will happen to TSH? TSH by default will come down, right? That is normal, right? So here, whenever there's a T3, T4 elevation, TSH has to drop. That is normal. So if it goes through the normal human feedback mechanism loop, the problem or the site of problem is in the thyroid, because thyroid produces more T3, T4, and definitely the T3, T4 in the blood is making the TSH come down, and that means I have a problem in the thyroid. Great. So anything which causes hyperthyroid state with respect to thyroid, that could be the cause. Could be a Graves' disease, toxic adenoma. These are the common hyperthyroidism causing disorders, right? Graves and toxic adenomas. Toxic adenoma is nothing but a follicular adenoma which produces hormones. We call them a toxic adenoma. Fine, perfect. So at the same time, when I have elevated T3, T4, and the TSH is also elevated, which means here the problem is not from the thyroid, the problem is from the TSH. TSH is so high and the thyroid just responds to the hormone level, that's it, right? So I have a problem with the pituitary. Most likely, I'll have a TSH secreting adenoma. Pituitary adenoma can secrete anything, whatever it normally can secrete, anterior as well as posterior pituitary. I can have prolactinoma, TSH secreting adenoma, ACTH secreting adenoma, right? Anything can be present there. So TSH secreting adenoma in the pituitary will also result in hyperthyroidism, and we call it as secondary hyperthyroidism, right? And then we'll come to primary hypothyroid, secondary hypothyroid. Same logic. Okay, so hypothyroid is based on the T3, T4 level, it's reduced. Again, the normal feedback mechanism is whenever the serum T3, T4 reduces, my body should stimulate the pituitary and say, please secrete more TSH because I have to compensate them, right? That's a normal feedback. If it is normal, my problem is in the thyroid, right? We have two big causes here, iodine deficiencies and your Hashimoto's thyroiditis. Even now in endemic area, iodine deficiency is the most common cause of hypothyroidism. In non-endemic areas, Hashimoto's thyroiditis is the most common cause of hypothyroidism, right? I have put here only the most common cause, that's all. Secondary again, same. Problem in pituitary, which means there's a pituitary apoplexy. When you go to gynecology, you'll read this for sure, right? So pituitary gets destroyed sometimes in an obstetric event. That we call it a pituitary apoplexy or Sheehan syndrome. Sheehan syndrome is postpartum pituitary apoplexy. The entire pituitary is destroyed. Or I can have a tumor compressing the entire pituitary and destroying it. That also could be a problem, right? So if pituitary is not functioning, hypopituitarism can also cause secondary hypothyroid, right? Again, see, this table gives two informations for me. How to interpret thyroid function test in a long answer question, and also the most common examples or classifications of hyperthyroidism and hyperthyroidism, right? As simple as that. So if someone says that classify the thyroid disorders, you have to put hyper, you'll have to put hypo, right? And then you can divide them into primary, secondary, and write the causes. Two causes is more than enough. Trust me, more than that, the examiner also will not have the energy to read. I am going to look for an hypothyroid, iodine, and Hashimoto. Hyperthyroid, Graves, and toxic adenoma. That's all. That's more than enough. The same table what we read, right? If you want to add more, okay, drugs. There are drugs you must have read in your pharmacology. Use that here. Your thyroid lowering drugs, they'll definitely cause hypothyroid state. As simple as that, right? You can definitely add that, right? At the same time, thyroid disorders can also be euthyroid. Can anyone tell me at least one example where I have a thyroid disorder, but it's euthyroid? The thyroid is abnormal, but the thyroid hormones are not changed. Anyone? Anyone example? Anyone example? Anyone example where you think that there's euthyroid, it's normal? One of the biggest example here are the tumors. Most of the tumors are euthyroid. I told, for example, your toxic adenoma. 10 to 20% of the adenoma are toxic adenoma. 80% of the adenoma do not secrete. They are completely normal. Papillary carcinoma thyroid do not secrete. Follicular carcinoma thyroid do not secrete thyroid hormones. Right? Every tumor in thyroid are predominantly euthyroid. So euthyroid also has a good amount of entity. Do remember them, right? Perfect. So we know the classification. Now we'll go to one classical hyperthyroid state, one classical hypothyroid state, that's Graves and Hashimoto's thyroiditis, right? Okay. Graves, with respect to pathology, I have almost nil involvement in Graves disease because Graves is a clinical diagnosis and a blood test biochemical diagnosis, that's all, right? Graves should have these features. Graves is diagnosed by a triad, right? That's what, when it was originally described also, they said that if these three features are there, it's definitely Graves. One thing you can add for any thyroid lesion, it is definitely more common in which gender, female or male? It's definitely more common in females, right? Most of the thyroid lesions are more commonly more than 5-6 times more common in females than males. You can add that as a template to any thyroid disorder. Graves should have all the three features. I should have a serum hyperthyroidism, I should have a diffuse goiter, and I should have infiltrative ophthalmopathy or dermopathy. Infiltrative ophthalmopathy causes the proptosis. Dermopathy causes the pretibial myxedema, right? Listen carefully. Generally, you must have learned the term myxedema is for hypothyroid state. So you might get confused in a viva. Pretibial myxedema is a finding seen in Graves' disease. It's a hyperthyroid event, right? It's not a hypothyroid state. Fine, perfect. Now let's see what will happen to Graves' disease. Graves is nothing but an autoimmune destruction to the thyroid gland. That's all. Fine. So for every autoimmune disorder, we have a template. We have a environmental insult, we have a genetic insult, then whatever the problem is in the lymphocyte is going to happen here, right? So here also we have environmental insult, we have genetic predisposition. These two genes are must to know. You have to remember this. I'll tell you why. PTPN22, CTLA4. Again, remember this. This can involve in Hashimoto, this can involve in Graves, this can involve in type 1 diabetes. Most of the autoimmune conditions in endocrine organs will have PTPN22, CTLA4 genetic polymorphism, not mutation, polymorphism. Because of this polymorphism, this patient's body is producing an autoantibody. There are two of them, two of the very known autoantibodies. Long-acting thyroid stimulator, LATS, thyroid stimulating immunoglobulin, right? These are antibodies, but they are stimulating antibodies, right? Same, type 2 hypersensitivity, if you remember our general pathology immunology class, in type 2 hypersensitivity, we have cell dysfunction. This comes under cell dysfunction. It does not destroy the receptor. It will alter the function of the receptor, right? Both are known. Both are important. TSI is more important because I have blood test of TSI to identify Graves' disease present or not, right? So these antibodies go and sit on the TSH receptor, which is present on the thyroid gland, right? So it binds to them. It mimics the TSH action and produces uncontrolled T3 and T4. So my body does not need T3, T4 here. My body is going to just produce more and more T3 and T4 because I have an antibody which sits on the receptor and acts like the receptor. Fine. Okay. Perfect. So here is a type 2 hypersensitivity. Like I said, it's an alteration of function or cellular dysfunction. If you remember type 2 hypersensitivity, we must have grouped two things in cellular dysfunction. One is myasthenia gravis and the other one is Graves' disease, right? So this is what happens in case of Graves' disease, a very simple pathogenesis. I have written it like this. For space, you write it one by one below. So it will easily occupy one page for pathogenesis. Enough. So how do I diagnose Graves? Like I said, Graves is a triad and Graves is a clinical diagnosis, right? Microscopy, FNAC is not done, but still I will tell you FNAC finding. No one does surgery or biopsy for Graves at all. Biochemical is required, clinical is required, right? So can now anyone tell me what will be the clinical features, whatever comes to your mind for hyperthyroid state? Because I can use them as the same template for clinical features of every hyperthyroid disorder, right? Anything which comes to your mind, Clinical features of hyperthyroid state. Anything? Few of them. I'm sure you know pretty much everything, or at least few of them. The clinical features of an hyperthyroid state. Few things are required and few things I want you to remember. Thyroid hormones function is to maintain normal metabolic rate, basal metabolic rate, right? So when there's more thyroid, the basal metabolic rate is more. BMR is increased. Because of increased BMR, weight loss will be there. Heat intolerance will be there. Tachycardia, palpitation. Every organ system functions more. Diarrhea will be there. Hair loss will be there. Hyperactive anxious nervous system. Proptosis in special sense, right? These are hyperthyroid. Hypothyroid, again, think exactly the opposite. Everything in the body is going to become slow in hypothyroid, right? So in hyperthyroid, I'm going to have an excess activation, increase in the BMR. Like you guys said, I'm going to have weight loss, right? I have diarrhea, right? Most important, cardiac signs, tachycardia, palpitation, even arrhythmias can happen in hyperthyroid state, right? You will have heat intolerance, like you guys said, right? Can be anxious, neural stimulation. Every organ in the body is going to work more except your endocrine. Endocrine alone will flip. In hyperthyroid, will have oligoamenorrhea status. Amenorrhea is a little bit unlikely. Oligoamenorrhea will be a better one. Fine. Okay. Others are already there, Rishi Kiran. Fine. So, and in hypothyroid state, exactly opposite. Hypothyroid, again, endometrium alone behaves differently. You'll have menorrhagia and hypothyroid state, right? Everything will be increased except for menstruation, which will be reduced oligomenorrhea. Okay, that alone will change, right? These are template. Again, I can write the template easily for any hyperthyroid state, right? Okay. I have answered that, Kaleem. Look into the Nischay batch once. If you don't get it, I'll answer it once again later. Fine. Okay. So now, I told in the starting point, I need triad. So clinical features is going to be around the triad. I have to make it. I will be able to see them, right? Ophthalmopathy is one of the most important finding. Why do I have ophthalmopathy? Here I'm having a lots of inflammatory cells. These inflammatory cells does not alone concentrate on the thyroid. They go into the periorbital tissue. It's chronic, right? Whenever there's chronic, I'll have more of stromal change. So I'll have excess accumulation of hyaluronic acid, glycosaminoglycans in the retroorbital space, which kind of pushes the eyeball to the forward, which causes proptosis. This could be a reasoning why question. Why do you have proptosis in hyperthyroidism or Graves' disease? You should know the answer. I'll have inflammatory cells, I'll have inflammatory tissue, I'll have healing tissue, along with that good amount of deposition of hyaluronic acid and glycosaminoglycans. The same thing happens here also. Same thing, the matrix material gets deposited in the subcutaneous tissue, which causes pretibial myxedema. Dermapathy, ophthalmopathy, in addition to whatever we already know. Diagnosis, FNAC is last. Diagnose only two things for me. To diagnose, I need blood test. Blood test, go to this table. I need to prove it is hyperthyroid and I need to prove it is primary hypothyroid. If I prove that, that's more than enough for me, right? So I say that T3, T4 is elevated, TSH is reduced. So I know the primary culprit here is the thyroid. So once I have that, I need serology. You can write immunology or you can write serology. Serology, I can do autoantibodies, like we do autoantibodies for multiple tests, right? So it's the same way we do autoantibodies, LATS and TSA will be positive. Once it's positive, I diagnose Graves' disease and you give hypothyroid drugs. You know more drugs than me, write that. Prescription of hypothyroid drugs for Graves' disease, that's all, fine. Now, FNAC. FNAC is not done generally. I'll tell you why FNAC is not done. First, it's an angry thyroid. I won't poke the thyroid. Because I poke the thyroid. Have you heard about complication in surgery called as thyroid storm? You must have heard about that. Same thing might happen. Because already in very active thyroid, if I poke it, I'm going to have some trouble, right? So I'm worried not to do it. But if sometimes by mistake, without evaluation, I put a needle, what will I see in microscopy? I'll have a classical finding called as FARRE flares. So what will happen is, you'll have thyroid follicular cells like this. You'll have thyroid follicular cells like this. It's hormones, right? These hormones will be seen leaving the thyroid cell. It'll be like this. It'll be like a fire. It'll be like a fire glowing. We call it FARRE flares. FARRE flares does not suggest Graves' disease. It suggests hyperthyroidism. That's all. This suggests hyperthyroid state. So even in a toxic adenoma, I will have this. Do remember it, right? In addition to that, it's autoimmune disorder. What cells you'll have? Lymphocytes. So lymphocytes and FARRE flares, It's suggestive of Graves' disease, but I don't do it anymore, right? No one does a FNAC or no one does a biopsy for Graves' disease because I have a problem of thyroid storm, right? That's for Graves' disease. I'll zoom out. Graves, most common in females. We have a triad to diagnose. We have a pathogenesis. You have a template clinical feature and classical features of ophthalmopathy and dermopathy and biochemical test, serology to diagnose and treatment. As simple as that. Done? Okay. Now, let's go the same template for hypothyroid state. That's Hashimoto. Okay. Now I'm going to ask you a few questions. You guys have to answer. Only then we are going to the next one, right? Hashimoto's thyroiditis. Can anyone tell me what is the type of hypersensitive reaction? Type of hypersensitive reaction in Hashimoto's thyroiditis. Hashimoto's type of hypersensitivity. If this comes in MCQ, my answer would be preserved to be type 4, right? But if there's an option of type 2 and type 4 both together, I will prefer type 2 and type 4, but it originates at type 4 and ends in type 2. This is the saga for almost any type 4 hypersensitive reaction. That template again follows for Hashimoto's thyroiditis, right? Okay. Hashimoto is undoubtedly the most common cause of hypothyroidism in non-endemic areas. That's very, very important. In iodine deficiency, still iodine deficiency is the most common cause. In non-iodine deficiency, Hashimoto's thyroiditis is the most common cause, right? So now let's go to the pathogenesis. Again, primary, I have both type 4 and type 2 hypersensitivity together. Any autoimmune pathogens for the matter, here also I'll have the same thing. The genetic predisposition, like I said, the same two genes, PTPN22 and CTLA4. Please remember this. Write it on top of endocrine. These two genes will be involved in every autoimmune pathogens of endocrine. Type 1 diabetes, same guy. Hashimoto, same guy. Right? Graves, same guy. Because it's polymorphism, what I'm going to have is, I'm going to have a T cell, primary problem in the T cell, which identifies the follicular epithelium to be foreign. So it destroys the follicle. That's where it starts with. T cell destroying follicles, automatically you know that it's a type 4 hypersensitive response. So once I destroy follicles, the same example I've been giving year long, once I break this pencil, I'll have two parts that will create neoantigen. My body will not identify them as two parts of the same pencil. It will identify, okay, I have a new antigen. Whenever I have new antigen, B cell will get activated. Why? Because B cell also has the same problem, right? Failure of tolerance. B cell is not able to identify that this antigen is not mine, right? It will fail tolerance and it happens. Inside, I don't have a template for osteomyelitis now. Okay, I'll add on to it later on. I'll put it here. Fine. Okay. This produces anti-TPO antibodies and anti-thyroglobulin antibodies. The most important thing is anti-TPO antibodies. That's the most important thing. You'll have anti-TPO antibodies, anti-thyroglobulin antibodies that will further cause gland destruction. It will start as type 4. It will end as type 2, destroying the entire gland. That's what is the pathogenesis of Hashimoto's thyroiditis, right? We know the pathogenesis. Now, symptomatology. Symptomatology, like usual, I said, I have a template for hypothyroidism. Write that. We have a template for hyper, we have a template for hypo, we're going to just fill that, that's all. Okay. But the most important thing is Hashimoto has a slightly different clinical feature, right? First, initially, okay, initially I'll have a very transient hyperthyroid state. Can anyone give the name? It's actually written there also. Initially, I have something called hashitoxicosis. We'll have a very transient state of hyperthyroidism. The reason why I'm having hyperthyroidism, this can be reasoning why question as well. The thyroid follicles, when they are destroyed, the hormones which are there can be released in the blood circulation. So for a subtle moment, I'll have an hyperthyroidism. After that, long standing, it will definitely become permanent hypothyroid state, right? So I want you to mention this when if Hashimoto is coming in a short answer, because I look for this transient hyperthyroidism and hypothyroidism, because if you diagnose the person at hyperthyroid state, you should not mistake and think of as a completely different thing. Please follow it up. Follow up is essential for everything in a medicine, right? So it might change, right? So my diagnosis will totally change from that point, right? Right? And obviously you write all the features of hypothyroidism. You know that there's a weight gain, there's cold intolerance, the patient will have constipation, the patient will have bradycardia, and obviously the patient will have menorrhagia, right? All the things will become less except for menstruation, which will become more in case of hypothyroid, right? How do I diagnose Hashimoto? I know the symptom, I've suspected it's Hashimoto, and I have to diagnose here. Yes, to prove it is hypothyroid state, I need a blood test. By default, the template will always follow TFT, thyroid function test, T3 and T4 is low, TSH is elevated, which means that thyroid has a problem. After that, what I'll have, I need to do FNAC. FNA is diagnostic here, and also biopsy can help me here, right? So what I'll see in FNAC, it's an autoimmune disorder. Any autoimmune disorder will have one inflammatory cell. I'm sure you can write that. That's your lymphocytes. You'll definitely have lymphocytes. That's one of the finding here, right? Second, apart from the lymphocytes, I'll have something called Hurthl cell. Hurthl cell can come in a viva. What is Hurthl cell? I must have told a dramatic explanation for that. If you remember that, great. Otherwise, remember, Hurthl cell is nothing but an oncocytic metaplastic cell. That's all. My T cells or the lymphocytes or B cells is destroying my thyroid. My thyroid follicular cell will not keep quiet. They'll fight back by producing more ATP. More ATP means more mitochondria. More mitochondria means more pink cytoplasm. That's all. This is the basis for oncocytes throughout the body. Abundant intracellular mitochondria make it granular pink color. We call it an oncocyte, right? So Hurthl cell is nothing but a process against a autoimmune lymphocyte. That's all. For an undergraduate, Hurthl cell is hallmark for Hashimoto's thyroiditis. But for a postgraduate, I want you to be prepared now itself. Whenever there's an external force, my thyroid follicle will fight back. I might see Hurthl cell. Predominantly, I'll see in Hashimoto's thyroiditis. That's it. Fine. Hurthl cell will be there. Lymphocytes will be there in FNAC, and in a biopsy or a microscopy in a HNE post-surgery, what I'll have massive lymphocytic infiltration. It can even form follicles. The moment I see follicles in a thyroid biopsy, I'll be more inclined towards Hashimoto. Can I confirm Hashimoto or should I call it lymphocytic thyroiditis? What do you guys think? What will be the diagnosis? Hashimoto or lymphocytic thyroiditis? Has to be lymphocytic thyroiditis, right? So how do I confirm Hashimoto? Obviously, I need serology. I need to do serology to prove the anti-TP antibodies, anti-thyroglobulin antibodies. If they are there, my confirmation of Hashimoto thyroiditis is absolutely right, because Hashimoto is an autoimmune thyroiditis. To prove autoimmunity, I need to have autoantibodies. Same with Graves. Template remains the same. Most common in women, hyper or hypothyroid, then the pathogenesis, that's direct destruction and antibody there. Here I have destruction, then you have autoantibody production here. That's all right. Then hyper hypothyroid, blood test then. FNAC is not done in Graves. Graves you go for serology directly and diagnosis. But here I do an FNAC, I can see a biopsy, then I go for your serology. Complications there in Hashimoto. Graves does not have complication. Hashimoto is a recurrent destruction, because how do I treat Hashimoto? We give thyroid replacement. We don't go and stop the destruction because destruction is already done, right? So I replace the thyroid, replace the hormones, give L-troxin forever for life, because the patient will be permanently hypothyroid. But the problem is the lymphocyte will still keep on destroying every new thyroid follicle formed. So I have an increased scope of papillary carcinoma thyroid. I have increased scope non-Hodgkin's lymphoma, which we call the maltoma. You have to write this complication without fail, because these two are well-known complications of long-standing case of Hashimoto's thyroiditis. Fine? Clear? Done? Any doubts? Do let me know. If not, let's go to the second topic in endocrine. That's thyroid neoplasms. Thyroid neoplasms can come in a essay question, right? Not denying that. If it's systemic pathology, if someone... that should be enough, Raviraj. See, that table is a crux of what I expect in an exam sheet. If you want to make it bigger, write it the same table in theory and put the table below, because that's all is thyroid function test. Beyond that, I am not going to do a thyroid function test. Free T3, free T4 does help me, but for a level, for a second year, T3, T4, T6 is more than enough, right? Okay. What's the most common type of thyroid tumor? Thyroid cancer? Simple one-liner. Can you name at least one finding? Comment the answer. I'll keep asking questions. Can you name at least one finding which you see classically in papillary thyroid carcinoma apart from papillae and psammoma bodies? Because I know that throughout life you're going to torture your examiner. Whenever they say papillae, you're going to say psammoma bodies, right? Apart from that, any one finding. Can I diagnose follicular carcinoma thyroid on a FNAC? Yes or no? That's the third question. Can anyone tell me one tumor marker for medullary carcinoma thyroid? I asked 4 questions. Papillary is the most common. There are multiple findings in microscopy of thyroid cancer. One of them is the classical Orfanani eye nuclei, right? I'm sure you'll remember that, the clear nuclear inclusion. Third, no, I cannot diagnose follicular carcinoma on FNAC because it needs a capsular or a vascular invasion. Either one of them is required, and that cannot be appreciated on FNAC, right? Rate concern. Correct. Tumor marker for medullary carcinoma thyroid by default is calcitonin, right? Perfect. Now let's go to the thyroid lesions. See, thyroid, for a long time, thyroid was not involving much in genetics. They said that iodine radiation is the cause, and that causes thyroid cancer. They left with that. They did surgery, removed it. Some recur, some doesn't recur. They left it. Of late, there's lots of inputs with respect to molecular genetics of thyroid. So I want you to remember at least for the important ones, right? Etiology, definitely this can go for any thyroid cancer, not just papillary carcinoma thyroid. Since 90% of papillary thyroid cancer, I'm putting the etiology here. But yes, Hashimoto can also increase follicular carcinoma thyroid. Radiation exposure can also increase follicular carcinoma thyroid, right? Okay, and radiation exposure. Previously, when I had ankylosing spondylitis in the spine, they irradiated here. So obviously thyroid is in the place, right? And any accident, any nuclear disaster which happens like Chernobyl, that's one of the important reasons why papillary thyroid carcinoma is very common in that place, right? So whatever may be the etiology, what happens in the molecular pathogenesis, the most common translocation, right? This is translocation. Please remember, RET will get translocated in papillary carcinoma thyroid. RET will be mutated in medullary carcinoma. Both are different but the same gene. To whom they will be translocated to? They will be translocated to PTC1, PTC2 gene. Not difficult to remember. PTC stands for papillary thyroid cancer 1 and 2, that's all. RET with PTC1, PTC2 gene, which increases nuclear factor K beta. That's a growth factor. That's all, right? That will increase obviously cell division. Right? That's the reason why I'm having more cell division. At the same time, I also have one more important mutation, BRAF V600E. Though that's not greatly useful in papillary carcinoma thyroid, but of late, we have started diagnosing them, we have started applying them because we have a targeted therapy. Whenever the therapy is there, especially this BRAF will be having more of extrathyroidal extension. When that's there, I can give a targeted therapy cousin, vemurafenib or darafinib. This is a targeted therapy for BRAF mutation. Since we have that, it's worthwhile identifying, it's worthwhile learning because it will alter the outcome of the patient, right? These are two important genetic alterations in thyroid cancer. So how do I diagnose them? For every cancer, it's simple, okay? Great, Jyotika. You have gross, you have microscopy. If required, I need IHC, and obviously we'll go to the prognosis, right? Gross, simple. I can have multicentric or unicentric. It can be multiple lesions in the same thyroid or only one lesion in the thyroid. I have a subtype called micropapillary carcinoma if it's less than 1 centimeter. This is 2.5, right? One phalanx is 2.5 approximately. If it's less than 1 centimeter, it's micropapillary. You cannot diagnose micropapillary. See, I have this big thyroid. Do you think less than 1 centimeter mass will produce a goiter? It won't. It will produce an enlargement. It won't. They are incidental diagnosis. You diagnose some other condition, tiny might be stuck there inside there, right? So very, very tiny ones, less than 1 centimeter is micropapillary carcinoma, right? We have an encapsulated variant of papillary carcinoma. We call them Lindsay tumor. Just remember, there's an encapsulated variant called as Lindsay tumor, right? This for gross. Gross, it will be gray tan, might not have much of hemorrhage. You won't be able to see much of papillae in the gross. So what I do in microscopy? Two things. I have FNAC as well as I have biopsy. Both the findings are very different, right? FNAC, yes, I'll have papillae. Whenever I see a fibrovascular core along with the cells surrounding them, I call it a papillae. Second, and the most important thing, which is seen only in FNAC, is the intranuclear inclusions, right? This is not for biopsy. Intranuclear pseudo-inclusions are seen in FNAC and not seen in biopsy. At the same time, some of you said orphan Annie nuclei. Orphan Annie nuclei is not seen in FNAC, it's seen only in biopsy. So please, under FNAC, don't write orphan Annie, it's a blunder. Because orphan Annie is a formalin artifact. It's not a finding seen in FNAC because in FNAC, I don't use formalin, that's all, fine. Intranuclear pseudo-inclusions, very, very characteristic of FNAC. And I have one more finding called in bubblegum colloid. Colloid is generally very thin. It's a protein. Here it looks like a very thick, like a bubble gum. Once you chew a bubble gum, it becomes stretchy, right? Like a bubble gum, it will be thick, ropey colloid. We call it a bubble gum colloid. If you can't remember others, at least remember this. Intranuclear pseudo-inclusions in FNAC is must. What do I see in biopsy? In biopsy, I have the orphan Annie nuclear. Orphan Annie nuclear is nothing but an optically clear nuclei. Here is not optically clear. Assume it's the entire nuclei. It will be predominantly clear. Why clear? Like I said, it's a formalin artifact. When I put thyroid tumors into formalin, We preserve them in formalin. The formalin kind of makes the nuclear chromatin disperse to the corner. So the entire nucleus looks, instead of blue, white in color. That's Orphan Annie eye. Orphan Annie is a cartoon character, as I told you. Orphan Annie's eye has no pupil. It looks completely white, completely made of sclera. So it looks like an Orphan Annie's eye. We call it an Orphan Annie eye nuclei. And wherever we have papillae, we'll have some homobodies, without doubt. Right? You'll have nuclear grooves, very classical grooving coffee bean appearance. Nuclear overlapping and nuclear crowding, kind of one and the same. So what happens is, I have a cell like this, it kind of overlaps like this, third cell overlaps like this. It'll kind of overlap, it's very much closer and crowded and it overlaps. That's nuclear overlapping and crowding. Again, a constant feature in papillary carcinoma thyroid. Histopathology, I'll see papillae, I'll see Orphan Annie. These two, if you write, you clear the sale already. Examiner is not going to go further. Coffee bean nuclei, extra finding. Some homobodies, extra finding. Nuclear crowding, nuclear overlapping, extra finding. Fine. We know FNAC, we know biopsy. You don't require IHC here. There's no other tumor in the thyroid which has Orphan Annie. So I can say it's diagnostic here. But there are few variants. If you're able to write the variants in detail, write it. Otherwise, at least remember the variants. For a pathology, there are close to 12, 13 variants of papillary carcinoma thyroid. For you, one is enough. But few of them, these make sense because it either helps. Sometimes misdiagnosis happens if I don't know this, or it will alter the prognosis. The variant called tall cell variant. If a cell is more than 2 times tall compared to the width, we call it tall cell. That's all. Extremely tall cell variants will have BRAF mutation, poor prognosis. Again, it's prognosis. Diffuse sclerosing variant. Too much desmoplasia. That's why it's sclerosing. It has the same findings of PTC, but too much intense desmoplasia, very aggressive, and the most problematic thing is it is seen in children. It can be seen in children less than 10 years, papillary carcinoma thyroid. It's not a tumor seen in adults. It's not tumor seen in adults only. I can have a wide range. Children, mostly it's a very bad prognosis and it's diffuse sclerosing variant, right? And one more, FVPTC. FVPTC, why it's required is, it has follicles. It does not have papillae. FVPTC stands for follicular variant of papillary carcinoma thyroid. The growth factor is follicle, but the nuclear features of PTC. It will have follicles with overcrowding. It will have follicles with clear Orphan Annie nuclei. Okay, it will have follicles with superb nuclear grooving, right? That's a variant again. Follicular variant, diffuse sclerosing variant, and tall cell variant, right? And can anyone tell me what's the most common location where papillary carcinoma undergoes metastasis? Mets? Any one place where they predominantly undergo metastasis? They spread to lymph nodes, right? You always have to look at the cervical lymph nodes. Lymph nodes are a very common place where they can spread, and spread to the lymph nodes automatically, drastically reduces the prognosis, right? That's about PTC. We'll just zoom out. Simple words. Etiology, radiation, chronic problems, or Chernobyl-like accident, two translocation, one mutation. We know the pathogenesis. Clinical features, you can write that there's an enlarged thyroid gland, firm nodular to palpate, that's all. Gross can be multiple, can be single. We have micropapillary variant, we have FNAC finding, we have gross finding, we have 2-3 variants, that's enough. And prognosis based on the lymph node involvement, fine. Jane, diagrams are actually your choice. I'm not sure if it's true. Some of your friends put that they are told in one of the university not to draw diagrams because this time they are going to evaluate your papers with computers, because computers is being scanned. So whether you do multiple colors or single color, it doesn't matter for the computer, right? That's what they told. I am not sure about it, but again, diagrams is your choice. But I'll be more than happy if you have a PTC, if you say that, okay, there's a papillae here with clear nuclei, draw it as an Orphan Annie and put as a papillae with a fibrovascular core and maybe some concretions here like calcification. It's a much more easy to catch. Rather than reading a theory, it's much easier to catch. That's all. Fine. Okay, let's go to the next guy, which is follicular carcinoma. Follicular carcinoma versus follicular adenoma, right? We call them follicular neoplasms. That's all. Usually the present is solitary thyroid nodule, a single tumor. Adenoma is benign, carcinoma is malignant. Adenoma is very well encapsulated. Most of them are cold, which is they don't secrete. Some of them are hot adenomas, toxic adenomas. They secrete your T3, D4. Toxic adenomas should be looked for, can become a cancer as well. Fine. So in a FNAC, I cannot differentiate a follicular adenoma or a follicular carcinoma for the simple reason FNAC needs, both of them will have the same finding here, repetitive microfollicles. Nucleomegaly will be there in both adenoma as well as carcinoma. I cannot differentiate. That's why we call it follicular lesion, that's all. Because for me to say something is follicular carcinoma, it either needs to have a capsular invasion or a vascular invasion. It is must. So what I see in microscopy is simple. In microscopy of follicular adenoma, I'll have repeated microfollicles, micro or small follicles, or even normal follicles, plus intact capsules. And for follicular carcinoma, the only thing required is capsular invasion or your vascular invasion, right? If we come to the molecular genetics of follicular carcinoma, RAS mutation and PAX8 and PPAR gamma, peroxisomal proliferator receptor gamma translocation will be there, fine? Okay? Not at all mandatory with H&E pencils. Don't worry about it. Which one, Himant? What in goiter? Okay? That's simple about follicular neoplasms. Follicular neoplasms alone will not come in a long answer, but reasoning why question can come. Why I cannot diagnose follicular carcinoma of thyroid on an FNAC? The answer is simple. I need capsular or vascular invasion to diagnose, which cannot be seen on an FNAC, so we don't go with that. That's it. Fine. Okay. Then medullary thyroid carcinoma. Medullary carcinoma of thyroid, everything is different here. Ravi, I don't want to antagonize your teacher, but I'll tell from a lecturer's perspective. If I am the teacher, I really don't care how good your exam is, how good your mark is. If you're able to diagnose patient, treat patient, make the patient happy, enough. Rest everything is useless. Honestly, rest everything is useless. Fine. Let's come back to this. Okay. Pathophysiology. Normally, not the right place. This for second year. Your seniors will see you first year soon. Fine. So origin, parafollicular C cells of thyroid. It does not come from follicular cells. It comes from parafollicular C cells. Normal function of parafollicular C cells is to secrete calcitonin. The primary mutation is RET proto-oncogene mutation, not a translocation. Fine. So now mutation. This mutation can be sporadic. 80% of them are sporadic only. 20% of them are syndromic also. Which syndrome? MEN2A as well as MEN2B. This needs to be mentioned. Please don't forget it. MEN2A syndrome, MEN2B syndrome, both of the syndromes will have RET mutations. Both will have increase in risk of medullary carcinoma thyroid. Fine. Okay. Medulla. The term medulla itself is simple. Medulla means soft. Cortex bone, medulla, right? So they are more fleshy tumors, unencapsulated and vascular lesions. They're not hard. We always say cancers are hard or firm, right? They are not firm. They're more fleshy. They are unencapsulated tumors, more vascular tumors. Microscopy has multiple different morphology. It can be polygonal, spindle cell, plasmacytoid, but the most important thing is amyloid. The moment you see amyloid in a history, in biopsy, or you have an image which says that, okay, apple green bilirubin is positive in thyroid, it has to be medullary carcinoma thyroid, right? It's an extracellular acellular amorphous material, which is nothing but ACAL. If you remember our immunology chapter, you must have read about ACAL. That's what gets deposited here. IHC, they are calcitonin positive. The most important thing is this part, okay? So let's say I told that 20% of the lesions can be syndromic, MEN2A, MEN2B. How do I know syndromic? For not everyone we do genetic analysis, right? So what we do is, if you have a lesion here, let's say this medullary carcinoma thyroid, what we look for is, you do a thyroidectomy, right? We look for these places, which for me is non-neoplastic. There's no cancer in the red color part. It's purely normal. The black one is the cancerous part, right? If in this part, I have C cell hyperplasia, okay? Which means here the problem is not restricted to the cancer. The problem is there even in the normal thyroid, which means it is inherited or syndromic, okay? Thank you, Avru. Okay, that's syndromic, fine. Please remember that this is the same logic what we applied for Wilms tumor and nephrogenic rust, which means even a normal kidney shows some evidence of Wilms, it's inherited Wilms. Normal thyroid showing C cell hyperplasia, it's inherited medullary carcinoma thyroid or inherited MEN syndrome. Fine. Okay. Thank you, Arnab. Okay. Perfect. That's about medullary carcinoma thyroid. Simple way to diagnose. Remember about the mutation. Remember they have soft in gross. Remember about amyloid, IHC marker, and C cell hyperplasia. That should be more than enough, right? We'll zoom out. That's with respect to your thyroid lesions. One last but not the least, anaplastic carcinoma thyroid. Few words. They are the rarest. they will have TP53 mutation. Good or bad? P53 is always bad for us, worst for us, right? They are very, very, very aggressive. The most aggressive thyroid lesions, and they are very fast growing. The problem of an aggressive, fast growing lesion is they don't just grow to the front, they go behind also. They go and compress the esophagus, trachea. They cause dysphagia. They cause hoarseness of voice, right? So when you have dysphagia or hoarseness of voice or stridor in a thyroid lesion, you think of anaplastic carcinoma thyroid. Microscopy is the anaplasia, is the worst degree of pleomorphism. You see worst degree pleomorphism, you can obviously call it anaplastic carcinoma, and they also will have spindle cell variant. Fine, that's all. That's all about anaplastic carcinoma thyroid. Just few words to remember. Okay, let's zoom it out. Fine, that's about thyroid lesions. We know about thyroid, both the thyroid disease and about thyroid cancers. Now, let's go to one part which we generally don't much concentrate about because we already know much about thyroid. So, diabetes, right? Diabetes, we know quite a few of them. Diabetes is diagnosis of diabetes these days is purely blood test. The polyphagia, polydipsia, no one even comes to that part because everyone start doing master health checkup at 30, 35. They'll pick up in pre-diabetic stage and start modification from that time onwards. Fine. Okay. Okay. Thank you, Ravi. So diabetes, if it comes in an exam, it's going to be a long answer question. It unlikely to come as a short answer question. They'll give you a scenario and tell you classify the diabetes, write the types of type 1 diabetes and type 2 diabetes, and also write a note on complications, right? So you need to know about the diagnostic parts. This diagnostic values keeps on changing. So when you are in internship, follow whatever values is that point of time which has been approved. As of now, these are the values. Normal fasting less than 100, normal postprandial less than 200, and normal random blood glucose. Right? It's random blood glucose. We'll ignore that for now. Fine. Okay. Pre-diabetic range 100 to 125 fasting, 140 to 199, and diabetes anything more than or equal to 126. Diabetes anything more than or equal to 200 random or your 2-hour postprandial is diabetic. And the most important thing, we are much more worried about HbA1c now because we know that patients cheat. We also cheat, right? Trust me, the moment you hit 30, you wanted to do a diabetic checkup. Trust me, the day before you will not eat. You know for a fact that if I don't eat properly for one night, fasting will reduce. Postprandial also will reduce. And you'll say, hi, I'm not diabetic. Now, HbA1c tells what I've been eating for the past 3 months, right? So we are more relying on HbA1c because it's a more standard value which don't sway with 1 day of fasting or eating more food, right? HbA1c is a very good determination factor of more than 6.5. You are diabetic and you need treatment. That's all, fine. Okay. Of late, this has been pushed a lot. Maybe in future, it will come into the diagnostic protocol also, which is continuous glucose monitoring. Put a device. It will not just say HbA1c. It will give you a spike throughout the day. You may have seen multiple Instagram influencers pushing it. Maybe in future, it may come into textbooks also as one of the easiest and way to follow a patient's diabetes mellitus, right? The classical examples or symptoms is polyphagia, polydipsia, polyuria, which we don't see these days because these days patient comes to you and say, doctor, I'm pre-diabetic or I'm diabetic. What do I do? That's all. Let's go to classification. We have type 1 diabetes, type 2 diabetes, the major chunk, and we have few inherited case of diabetes like MODY, maturity onset diabetes of young, mutation, single gene diabetes. Those are very rare, but type 1, type 2 is something which is important for us. Type 1, as you know, is due to insulin dependent diabetes mellitus or due to the problem of less secretion of insulin by beta cells. Type 1 is a pure autoimmune pathogenesis. I told first itself, I am repeating the same. Across entire endocrine, you will have this gene, CTC and PTPN22 and CTLA4. It will be there by default. Polymorphisms in that, and please remember this HLA. These HLA are important. Okay. HLA DR3, DR4, which is important, which is more seen in patients with type 1 diabetes. Plus an viral hit, viral infection or an environmental toxin. For autoimmunity, we need that template, right? This is going to cause type 4 hepatocytic, which is T cell mediated destruction, which means because of the genetic hit and an abnormal lymphocytes genetics, I am going to have a T cell which will recognize beta cells as foreign. That's all. The T cell will recognize beta cells as foreign. The moment it identifies them as foreign, it will destroy it. Insulinitis. Destruction we call it an insulinitis. The moment it destroys beta cells, obviously you'll produce neoantigen. That's by default the routine, right? I break a pencil again, I'll have two spots, I destroy beta cells, some of them will be considered by my B cells as neoantigen. So I have here abnormal B cells. They'll consider them also as foreign and they produce this antibody called as anti-GAD antibodies. Anti-GAD antibodies is used to diagnose diabetes. It's not type 2 hypersensitivity, it's type 4 hypersensitivity only. For most of the type 4, you will have autoantibody. Doesn't make it type 2. Please remember that you might miss in a one-liner. Celiac disease, T cell destruction, I'll have anti-TTG. Here also I have the same. Hashimoto, T cell destruction, you had anti-TPO, right? They're all T cell problem, type 4 hypersensitivity, but the output can be a type 2 hypersensitive antibody, which will use it for diagnosis, fine? Okay. So over the period of time, what happens is, see, these are stages. This is my entire pathogenesis. Doesn't mean that today I'm having a problem, my lymphocyte is destroying my beta cell, I'll become diabetic tomorrow. No, there's a stage, right? We have 3 stages of type 1 diabetes. First, the autoimmune process starts. The patient is still normal. Normoglycemic, asymptomatic, nothing happens. Beta cell still slowly reduces, right? Stage 2, there's progressive decline in the beta cells. The amount of beta cells is reducing a lot, okay? Patient is dysglycemic, no symptoms. If I do a blood sugar, might be abnormal, but still the patient is not symptomatic, right? Stage 3 is severely depleted beta cells, where the insulin levels are very, very, very low, not able to tolerate, and the patient will become symptomatic. Type 1 diabetes is not that it's seen only in children. It can be seen in any age group, but predominantly seen in a younger age group compared to type 2. Type 1 diabetes has more risk of complication because it's unnoticed. No one expects a 13, 14-year-old kid to have diabetes. They'll keep on ignoring the symptoms, right? So here, when I say overtly diabetic symptoms, complications. Complications are a little bit more common in type 1 diabetes, right? Uncontrolled diabetes. You can have diabetic ketoacidosis, hyperosmolar coma. You will read them in medicine. These are also there. That can be the presenting symptom of majority of type 1 diabetics. That is type 1 diabetics, right? So for me, how do I prove type 1 diabetics? I prove it's diabetic with the help of the blood sugar level and HbA1c. Same as the table which you saw first. How do I prove type 1? Serology. So in serology, I can see the anti-GAD antibodies. That's one. And the easiest mention is, look at insulin levels. I can easily measure the insulin levels. If the insulin levels are low, by default it's type 1 diabetes. And you guys know the treatment. What's the treatment? Give insulin injection, that's all. Type 1 diabetics needs a lifelong insulin replacement. There are lots of variations of insulin available. You know, short-acting, long-acting, lots of them. Basal insulin, lots of them. You write accordingly, fine? Now let's come to the most common type 2 diabetic. What has changed the epidemiology is, when I was reading second year of MBBS, we have been told always that type 1 diabetes under 30, type 1. Diabetes above 40, type 2. Perfect, clear distinction. Now that distinction is narrowed because of excess consumption of junk from childhood. Type 2 diabetes has become way common in younger age group. 25, 26, we see people who are obese and type 2 diabetic, because they've been destroying the pancreas from childhood. Previously, we started destroying pancreas only at 25, 35. That's why we had type 2 diabetes 40. Now, it's becoming the reverse. So, age is not going to help me. We have always been told that genetic feature will be there. Dad is diabetic, mom is diabetic, child should be diabetic. That has been broken. Yes, there are few risks, but it's not that because of the dad only you got diabetic. In type 1, maybe yes, but in type 2, it's not that, fine. So, in type 2, it's a combination of peripheral insulin resistance and inadequate compensatory insulin secretion. This part is very important. We always say type 2 diabetes is insulin resistance. No. It is a combination of insulin resistance plus reduced insulin secretion. It's both. We'll see why both very soon. Okay. So predominant cause of type 2 diabetes, you know that, is obesity. Excess adipose tissue, especially in and around the belly, the central fat. That's the most important thing. More adipose tissue produces more free fatty acids. Not just that, adipose tissue is a very, very, very active tissue. They produce pro-inflammatory cytokines. That's why obesity is a risk factor for cancers. It puts the entire body into a hypermetabolic state and autoinflammatory state. Fine? We'll come to it soon. Wait. Animated G. Okay. Then I'll have reduced adiponectin. Adiponectin is a good adipokine which helps us to counteract the resistance. I'll have less adiponectin, more free fatty acid, and more pro-inflammatory cytokines. Fine. Okay. Then this free fatty acid converts to one of the important products called diacylglycerol. If you remember the free fatty acid metabolism in your biochemistry, diacylglycerol is an intermediate. That diacylglycerol product is what is going to stop the insulin receptor. It goes and sits on the insulin receptor and does not let a normal insulin sit on that. Okay, it's an inhibition, that's all. Imagine it's like a competitive inhibition which produces insulin resistance. So insulin is not working. Since insulin is not working, okay, can you ping me Vivo phone? I'll help you for sure. Since insulin is not working, there is reduced utilization of glucose by the muscles because insulin is required for me to utilize glucose by the muscles. I will not be able to use the glucose. At the same time, when my muscle is failing to use glucose, my liver is saying that, okay, I'm increase the gluconeogenesis in the liver, right? These two combination results in hyperglycemia. Peripheral insulin resistance plus the liver try to compensate and produces more glucose, gluconeogenesis, which causes hyperglycemia. Now the problem does not stop here. The moment my body has hyperglycemia, can anyone tell me how will my pancreas react? How will pancreas react? Pancreas reacts in a simple way. It will produce more beta cells, more insulin, right? Initially, I'll have a compensatory phase where my pancreas will say that, okay, there's an insulin resistance. I'll produce more insulin, competitive inhibition to overact the resistance. I'll compensate that. That's the same way we also treat sulfonylureas. What does sulfonylureas do? They produce more insulin secretion. That's all. Sulfonylureas increases insulin secretion. That's it. So initially, I'll compensate. No problem at all. We'll put sulfonylureas to compensate it more. The problem is this is not a solution. The solution is to take care of the resistance, not to just to throw more and more and more insulin to let the resistance be there. But this will fail over a period of time. Over chronicity, the adipose tissue itself is directly toxic to the beta cells. First problem. Second problem, more and more and more and more insulin you produce, we read in amyloidosis chapter, I'll have the insulin's breakdown product. That is your IAPP, islet associated polypeptide. That gets deposited there. Will amyloid cause destruction? It will. So over the period of time, beta cell will get exhausted, beta cell will get destroyed. What will happen to this time in type 2 diabetes? You will by default have reduced insulin. That's why people who are having type 2 diabetes, after being on drugs for 20-30 years, they end up in moving to insulin injections because I don't have insulin anymore there because there's no beta cells at all. This happens by default. That's why I said at the start, it's not just insulin resistance. It's a combination of insulin resistance and reduced production of insulin on a long term. Both happens in type 2 diabetes mellitus. It starts as insulin resistance only, but it'll end in hypoproduction of insulin by default. Fine. Okay. That's about your type 2 diabetes mellitus pathogenesis. The best way to treat this, it's a metabolic disorder. Take care of your metabolism. Work more. Burn your calories. It's not about eating. Yes, if you eat less, happy. But work out more. Burn the extra adipose tissue. More adipose tissue you burn, less free fatty acid is there. Resistance will reverse. If I throw more and more and more insulin, it's going to bite our back at some point of time. Fine. True anemia fanboy. At the same time, we also should change a little bit, right? Let's start running so that we'll destroy the $60 billion insulin industry. Fine. Okay. Now let's come to the rare types of diabetes mellitus. MOD wise, maturity onset diabetes of young. Need not read in detail. Just remember the name. Apart from type 1, type 2, I have few other things as well. MODY1, it's HNF1 alpha mutation, hepatocyte nuclear factor. MODY3, glucokinase. You remember the glycolysis pathway? I can have mutations in them, which also can cause. Endocrine diabetes. Cushing's causes hyperglycemia because steroids will interfere in every metabolic pathway and cause more glucose production, hyperglycemia. Pheochromocytoma, thyroid disorders sometimes can cause hyperglycemia, right? Again, if I take 100 cases, this might be like 0.1, 0.2, that's all. Rest everything others. Sajeev, if it's FNAC usage in thyroid lesions, you can write every single lesions, write the FNAC finding until these are the cases where it's used, and the end with follicular carcinoma, I cannot diagnose the FNAC also. That's enough. Fine. Okay. Type 3 diabetes, it is pancreatogenic. When pancreas gets destroyed due to any other lesion, chronic pancreatitis, obviously endocrine part of the pancreas also will be destroyed. Pancreatic cancer, I do an pancreatectomy. I cannot say that I leave endocrine alone and remove exocrine part, right? Everything will be removed, right? So all that also will be causing diabetes. Again, these are not that common. They are pretty rare, fine? These are the other types of diabetes mellitus. Now, let's look at the complications of diabetes. Saji, very good question. I'll take Saji's question. He said that there's a question on FNAC usage in thyroid lesions as a short note, right? See, first guys, remember one thing. If a question comes outside the textbook, the first thing is don't start writing. Please think for 5 to 10 seconds because it's a very vague question. Vague questions has more answers than a very specific question. If I ask you, write the FNAC of papillary carcinoma thyroid FNAC as short note. You can write maximum 4 points. Beyond that, there's nothing there. But it's a very vague topic. When it's a vague topic, write from the first. First, FNA is one of the diagnostic tool in diagnosing thyroid lesions. Second, it's adjuvant to your medical biochemistry, that's your blood test, and sometimes it should be complemented by biopsies or histopathology. Done? Third, how do you do an FNAC? Because in cytology section, I taught you that in the Nishchay batch, FNAC is a fine needle aspiration cytology. One, I can do it blinded. If I have a goiter, I just poke it here. Second, I have to do it targeted, ultrasound guided. How do I do ultrasound guided FNAC and why do I do it? If I have this big goiter and here is a tiny solid lesion, let's assume this is a papillary carcinoma thyroid here, in this big goiter. Naked eye I can't see, but in ultrasound I can see that, okay, I have a lesion here, so I'll focus the needle here. So I have extra point. I have to do ultrasound guided FNAC to increase the precision, right? Done. So what is FNAC? Types of FNAC. Now use cases. You definitely know few use cases. Hashimoto, you know finding, you know. Papillary carcinoma, you know. Follicular adenoma, you know. Medullary carcinoma, you know. Anaplastic carcinoma, you know. 5 is enough, no? Start with that. FNAC can be used to diagnose non-neoplastic as well as neoplastic lesions. For example, in non-neoplastic lesion, write about Hashimoto's thyroiditis. I can see so-and-so finding in Hashimoto's. Second, write about a simple colloid goiter. I will see colloid and thyroid follicular cells. Third, about Graves' disease. Cancer, neoplastic, follicular lesion, adenoma, carcinoma I cannot diagnose. Then papillary finding, medullary you'll have amyloid and spindle shaped cells, anaplastic cells, right? If a question is very vague, like what you said, I won't call it vague, rather it's very generalized question. You have lots of options to write if you think for a few minutes. Please don't let go of the habit of thinking. That's the most important thing. These questions improve you as a person because this is what is required when you go and sit in the consultation room and there's a patient in front of you. They don't have syllabus, right? They'll ask any question. Please, general questions are very good. Don't worry. And they also will have a soft corner. Okay, they have written something, so let's give some mark. Fine. Okay. That's enough, Sajeev. That's what is expected from you also, right? As an undergraduate, I look at how you approach a bouncer question, not that whether you're writing it right or not. Fine. Perfect. Let's come back to this. So we read about type 1 diabetes, type 2 diabetes. Chronic complications of diabetes are predominantly for type 2 because type 1, like I said, allow more acute complications than chronic complications. Fine. Which part, Sajeev? 2 marks is enough. You write the name, that should be more than enough. Fine. So chronic glycemia, hyperglycemia, we have something called a non-enzymatic glycation of proteins happens to the blood sugar. So which results in the product called an H products, advanced glycated products, right? H products has 2 mechanisms. One, they are just going to deposit surrounding the blood vessel, which causes narrowing of lumen. Let's assume this is a blood vessel. H products keeps on accumulating more and more. Obviously, it will narrow the lumen. That's one complication. Mechanical deposition of H products. Second, I have a receptor called as RAGE. RAGE expansion is receptor for H products. Remember, it's pro-inflammatory. That should be more than enough, right? So the H product sits on the RAGE receptor and increases inflammation, right? So these both is going to activate pro-inflammatory cytokines, react to oxygen species, procoagulant, and cause vessel damage. At the same time, it's going to reduce the lumen. Predominant of the diabetic complications are vascular complication, macroangiopathy or microangiopathy. Why vessels are targeted? Because the chronic hyperglycemia results in H products, which is going to cause all these problems. Fine. Okay. Now, microvascular complications. Nephropathy. If it's a 5 mark, I want you to write few points about diabetic nephropathy. You know about KW lesion. You know about Armani-Epstein lesion. Write that here. Okay, retinopathy. It can damage the retinal vessels. Not just that, it can also increase the risk of cataract formation. Because in cataracts, if you've gone to ophthalmic posting, you must have read about a molecule called as sorbitol. Sorbitol increases the formation of cataract and diabetes. That's also age product, right? It's an altered product of the blood sugar only, right? Neuropathy. Again here, it's not due to the damage of the nerves per se. It's the vascular damage which destroys nerve. Nerve is there. There should be a vessel supplying the nerve, right? That vessel will be damaged. So I'll have neuropathy there. Fine. Got animated. Macrovascular complication, yeah. Accelerated atherosclerosis. Again, if it's only a 5 mark question, elaborate it, otherwise ignore it. Fine. Atherosclerosis, as such, this is not the only cause. It's one of the risk factor for atherosclerosis, along with your hypertension, hyperlipidemia, and many other things, right? Diabetic foot ulcers. Diabetic foot ulcers has two things. Neuropathy can increase the risk of ulcer because you walk and there's no sensation. Tiny prick, you won't even recognize. That's where the ulcer starts. Second, on the top of that, I have microangiopathy. There's a tiny ulcer which would heal. For healing, I need granulation tissue, right? When you don't have granulation tissue, what will happen? It will not heal. That's why you have chronic non-healing foot ulcers. It's a very, very classical complication of diabetes mellitus, right? Ignore this part, fine? So these are few complications of diabetes mellitus, which you have to remember. Rage, age products, how do they cause it? And few words about few of the important complications, fine? Done? That's in short about diabetes. Okay? Any doubt in diabetes? Do let me know. If not, let's go to the next. See, okay, Raviraj, acute complication of diabetes mellitus, two things: diabetic ketoacidosis and hyperosmolar coma. Right, these are two other acute complications of diabetes mellitus. Armani-Epstein lesion, KW lesion. KW lesion is a nodular form, glomerulosclerosis, where the same age products accumulates in the glomerulus, produce a big nodule. That's KW lesion, which is a microscopic hallmark of diabetes. Armani-Epstein lesion is nothing but your glycogen which is getting accumulated in your proximal convoluted tubule, because glycosuria, you'll have reabsorption which gets accumulated, which is seen as clear vacuoles in the proximal convoluted tubule. Fine? Done? Okay. Few of the non-specific topics. I'm not sure if they'll ask, are they still asking wound healing? If they're going to ask wound healing, Dreamcatcher, that's where we started with the diagnostic criteria. Okay. I won't be the person who will be asking fracture healing because you have an entire subject of orthopedics, like I said. But yes, we'll look superficially at fracture healing. We'll look at rheumatoid arthritis. We might look at Paget's disease, bone tumors, and few topics with respect to bone. Fine. Fracture healing. The template is like wound healing. Normal thing what we read, slight alterations in the terminologies. That's all. Fine. It's similar to wound healing, but the slight alterations in terminology because skin and bone is not the same. Right. The first phase is inflammatory phase. The second phase is reparative phase. The third phase is remodeling phase. Generally in wound healing, we don't consider much about remodeling. But in bone healing, remodeling is very important because bone healing is not about the cosmetic. It's about the weight-bearing nature of the bone, which requires good amount of remodeling for me to come back to normal. Fine? Okay. Now coming to the first. The moment you have fracture, bone breaks. Definitely 100%, the blood vessels surrounding the bone will break. Remember this. If you slip an ankle or a toe, it will swell. One of the easiest way for me to differentiate a sprain and a fracture. Sprain is ligament, fracture is bone, is hematoma. Ligament generally does not cause hematoma unless it's very severe. If there's a hematoma, which means the bone is broken, tiny capillaries in the bone is gone, so I have a big hematoma there. So first of all, you'll have hematoma. That's the first thing, right? You'll immediately have a hematoma at the fracture site, right? This hematoma is very, very important. That's why we stabilize the bone. You must have definitely been to casualty postings. If not, please go and have a look after your exams. The moment bone is broken, you'll put a slab and we'll immobilize it. Why? Because this hematoma is of utmost importance for me. That's why I say traditional way of bone healing is not important. Nagpur, AIMS, just give me a second, I'll answer soon. Fine. Traditional bone setters will massage it, so they'll dislodge the hematoma, right? That's why for me this is very important compared to the hematoma formation is very important and immobilization is very important, right? Once you have hematoma, the platelets will be there, inflammatory cells will be there. Every hematoma has that. Platelets gives me PDGF, TGF beta. These are the growth factors which will start the healing formation. These growth factors will stimulate the bone progenitor cells, which are stem cells in the bone, right? And they'll form a fibrin meshwork, tiny hyaline cartilages, and tiny fragments of bone, right? This is your procallus, right? So here, from this part, I'll start forming a little bit of hyaline cartilages, broken tissues, and fibrin meshwork, which will kind of bridge the tissue. We call it a procallus, or we call it a soft callus formation, an early soft callus formation. In this time, there's no weight bearing there. 0 to 2 weeks, even if you have broken bone, you should not bear weight there. Fine. Okay. Hi Himanshu. I don't know much of Hindi, so I'm comfortable in the English. अगर if you have any doubt, हिंदी में पूछो, मैं English में धीरे-धीरे सवाल दीजिएंगे, ठीक है? English Hindi is not that great. Fine. Apologies for that. Okay. Then let's go to reparative phase. Reparative phase, this hyaline cartilage undergoes ossification. In your embryology, you must have read about endochondral ossification, right? That's what primarily happens here. You have endochondral ossification. All the tiny fragments of hyaline cartilage starts forming bone a little bit. So let's say I have a gap here and there are like 20-30 bits of hyaline cartilage here. All the 20-30 bits of hyaline cartilage starts forming bone. So what will happen? They will slowly merge. So the procallus or the soft callus becomes a hard callus or a bony callus here. But you know for a fact, these are not proper bone like this. They are bits and pieces attached like a Lego brick, right? So I'll have bones here, which will be attached here like this, multiple things. It's not a uniform structure. We call this bone as a woven bone. This is very, very important. Here I have a bone, but yes, I can weight bear, but very limited. You cannot run and jump because still an immature bone, right? Next is remodeling. The initially formed bone, this bone which is formed by bits and pieces, we call the bone woven bone. But I don't want woven bone. What gives me strength is a lamellar bone. So what happens next is, so I have woven bone here, bits and pieces of bone which is formed here. The next thing is my osteoblast, everything comes, removes the woven bone a little bit, and then let's say, okay, the woven bone is still there, and I'll have the new bone formation which will be proper lamellar bone. Slowly and steadily, osteoclast comes, removes the woven bone, lays on a normal bone. Removes the woven bone, lays on a normal bone. It will take months to years. Based on age, gender, nutrition stages, lots of things there, right? It will take a long time, and ultimately it will become lamellar bone. Lamellar bone formation alone is not complete. Again, lifelong it will keep remodeling. Your bone, my bone, now also it grows. Not lengthwise, but remodeling happens lifelong, right? Even at the best case, I can get 70 to 80% of original strength. I will never be able to get 100% of original strength like any other wound healing process, right? The same thing, what happens in skin, but different phases: inflammatory, hematoma, growth factors, soft callus, which contains your hyaline cartilage. Then second stage of reparative, bony callus, everything forms, becomes a woven bone. Third stage of remodeling, woven bone becomes lamellar bone and remodels throughout life. Fine. Okay, Pratima Ames Nagpur, where did you read it and give me the context? Without context, what I can say, why a fractured hip can heal faster than a fractured tibia is, fractured tibia bears weight. There are lots of muscular attachments there, right? So even though if you have a plaster of Paris cast, suddenly you flick your, I have muscle here, right? I immobilize this joint, but finger movement also might alter this muscle force, right? Because I have mechanical pressure there. That might be the reason. But again, it's not easy for me to compare. There are different types of fracture, different types of damage, comminuted, non-comminuted, open, close. Based on that, it will automatically alter. Age, everything alters. Fine? Fine? Okay. Now, fractures which can delay fracture healing, right? Age definitely delays fracture healing, and poor nutrition status. Generally, the person is weak will definitely delay fracture healing, right? Local sites, micro movements. See, micro movements are okay for me. That's why I immobilize the bone. But yes, I can move a little bit. But if I don't immobilize the bone, right, it's not comfortable for me. It will definitely cause a spot, right? Yes, Raviraj. Infarction. Open fractures are definitely more complicated than closed fractures because infarction, something comes inside, it will destroy everything, it will cause. Infarction. I don't have enough blood supply. A major artery is cut in the fracture side. Blood supply is not coming back normally. It will definitely cause a problem, right? Foreign body. Again, at the same time, when I'm going to, just give me a second. I don't know how to make this zoom. Yeah. When I'm going to have a tiny bit of external particle coming into the part in an open fracture, again, it will not heal properly, which will cause problem, right? Drugs, very, very important. Steroids. Steroids affect inflammation. That's why steroids affect almost every wound healing here, right? Since it affect inflammation, it will by default affect wound healing, right? Complications of fracture healing, right? Fracture healing complications, you must have seen them in orthopedic posting. Malunion, one of the important thing is gunstock deformity. You must have seen the supracandular fracture not uniting properly. Normally, if it unites here, it unites like this, malunion. That's important. Second, non-union or delayed union. It does not unite properly, or it's going to delay. Normally, I have like 3 months to 6 months. It might take 1 year or 2 years. That's also a problem because of above said factors. In very rare cases, I can have false joint formation. Fine. Do they ask, Sajeev? If they ask, I'll definitely help you out. So here, I don't have a joint formation here, but there's a possibility if I radius and ulna breaks, it can fuse separately, and my hand can bend it between. That's called a pseudoarthrosis. It's particularly common in tibial fractures, where pseudoarthrosis is very well known, where I have a pseudo joint formation without the presence of a joint in that place, right? So these are the stages of fracture healing and the factors which affect the fracture healing. Fine. Okay, next about pages rheumatoid arthritis. Rheumatoid arthritis can come in a short note. Important things I want to tell. Do remember them. It might come as a long answer in orthopedics. I don't expect them as a long answer with respect to second year MBBS at least. Fine. First, rheumatoid arthritis and rheumatic heart disease are not the same. It's different. I'm saying this because in Viva, you might blurt out the wrong answer. So listen carefully what they ask in Viva. Okay. It's not a bone disorder. It's a systemic inflammatory autoimmune disorder. I have rheumatoid arthritis, rheumatic vasculitis, rheumatoid skin nodules, rheumatoid problems in your eyes. So it's a systemic inflammatory autoimmune disorder where arthritis is one of the important things. That's all. It primarily affects the smaller joints. Knee joints, bit rare, right? Your proximal, interphalangeal, metacarpophalangeal, these joints are more commonly affected. Wrist, yes, it might affect the major joints also, but not that common as compared to smaller joints. Fine. Okay. So what's the problem here? HLA-DR4, have to remember, this is a predisposition. Trigger, smoking is a very important trigger, and periodontal infections. So in people who have an altered immune system, the smoking kind of, or an environmental insult kind of malforms one of the simplest protein. What they do is they citrullinated. Citrullinated is a chemical modification of a protein, right? So alpha collagenase, alpha enolase, these enzymes are broken down because of the environmental insult of smoking or the infections, and they are citrullinated. This is the neoantigen here. This citrullinated protein acts as a neoantigen, and my body will produce antibodies against them. Same way, type 4, type 2 combination, right? So B cell recognize them as neoantigens. Once the neoantigens are there, automatically it goes and produces autoantibody and destroys the entire joint space. If it's arthritis, skin, vessel, wherever it's there, it will destroy that part, right? Primarily, it is Th1 pathway. Sometimes it might also activate Th17, especially in nodules. I might have a little bit of neutrophils as well, but primary is a Th1 mediated destruction. Type 4 hypersensitivity only is going to be there in rheumatoid arthritis. Fine. Okay. So what are the antibodies I see? There are two antibodies which we expect from an undergraduate. One is rheumatoid factor. Second is antibody to citrullinated peptides, right? Anti-CCP, this is very, very specific, not sensitive, very specific, because citrullation is the key in the pathogenesis. Okay. And rheumatoid factor. Rheumatoid factor is more sensitive and less specific. It's used for screening purpose. It's nothing but an IgM antibody against the FC receptor for IgG. It's actually an antibody against an antibody. Rheumatic factor is very commonly used. Fine. It's a growth factor, right? IGF-1 acts as a growth factor. It promotes any growth. So obviously it's going to promote healing as well. Fine. Okay. So what do we see in gross? Though I don't see rheumatoid arthritis biopsy, but I can envision what will happen in the gross in the joints. I have a tiny joint here where there's lots of inflammatory cells and the synovium is going to react. So first and the foremost thing, I'll have reduction of joint space. How is useful for me? I'll see them in X-ray. In X-ray, I see a reduced joint space. By default, I'll have destruction of cartilage. I can definitely look at the MRIs and say that, okay, the cartilage destruction is there. Over the period of time, what will happen? The entire joint will fuse together, which we call them ankylosis, because deformities are very common in rheumatoid arthritis. Ankylosis is also very common in rheumatoid arthritis. So what do we see in biopsy? The classical finding in biopsy is PANAS. If you write this term, that's enough for me. PANAS, P for papillary. So what is PANAS is? It's nothing but a papillary hyperplasia of the synovial membrane plus lymphoplasmatic infiltrate. That's all. The synovium grows so big, undulating membrane becomes a papillary projection. Along with that, underneath that I have lymphoplasmatic infiltrate. The word PANAS is what I expect from an undergraduate, right? So what is the problem if there's a PANAS? The problem is this, that's a classical symptom. They might ask you why there's a early morning stiffness, which is very classical for rheumatoid arthritis, right? Let's assume this is the space. This is one bone, this is one more bone. The space between the joints, okay? And here I have two membranes there. Those are the synovial membranes of the opposite bones. So when you rest, what happens? They kind of merge with each other, right? They merge with each other because both are papillary projections. They kind of merge with each other. The moment you wake up, you're going to break it. You're going to break it. You're going to break it. So waking up, flexing the joints will be very tough. We call it stiffness. It's not more than pain, it's stiffness. Extreme amount of stiffness on waking up is a classical finding of your rheumatoid arthritis because of the PANAS of the opposite joint surface interlocks with themselves and becomes difficult. And more you move, you will create the gap, right? Automatically over a period of 30 minutes, you'll automatically create a gap. Then everything will automatically settle. This is a classical finding of rheumatoid arthritis, early morning stiffness. Any question, early morning stiffness, fingers, it's rheumatoid arthritis, classical, fine. And extra-articular, like I said, it's not just bones. I have rheumatoid nodules in skin, seen on the extensor surface of the skin, right? You will see central area fibrinoid necrosis along with histiocytes surrounding them. Rheumatoid vasculitis, it's a leukocytoclastic vasculitis. If you remember vasculitis, we must read that leukocytoclastic as neutrophils. That's why I said rheumatoid is not only Th1, also Th17. Sometimes you'll have neutrophils as well as your lymphocytes. Acute necrotizing vasculitis, la fibrinoid necrosis, and la neutrophils in the blood vessel. Fine. Diagnosis, primarily clinical features. Serology, you can see anti-CP antibody and RA factor. Rarely you need a biopsy. Maybe for rheumatoid nodules and vasculitis, I might require a biopsy, but definitely not for rheumatoid arthritis, right? Okay. And treatment, I'm sure you know the treatment. You know about normal drugs and also the disease-modifying drug in rheumatoid arthritis. I'm sure you'll be able to write that. Fine. Okay. Fine. Done. Other whatever helps you learn. Doesn't matter. Okay. Fine. Perfect. That's about rheumatoid arthritis. Now, let's come to the next question. That's Paget's disease. Again, Paget's is not a very common question. Maximum what I can have is a 5-mark question for Paget's. We'll learn what to write for 5 marks for Paget's disease, right? The first thing, Paget's, if they're asking, please see what Paget's they are mentioning. Is it the Paget's disease of bone or an extramedullary Paget's disease which can happen in the external genitalia, or they're asking Paget's disease of breast. There are 3 pages. Please don't confuse and write what they're asking. If they just ask Paget's disease, I really don't know what to write. I will leave it to you. Maybe write all 3 and say there are 3 different types, or explain one and write a little bit about other 2 as well. Fine. Okay. Paget's, what happens? A chronic disorder. The only problem and the easiest way to remember Paget's is normally osteoclast and osteoblast will bind to each other and function uniformly. Osteoclast removes, osteoblast lays down. They have a proper synchrony. But here there's an asynchrony. That's a problem, right? So what happens here? Osteoblast will sometimes start functioning independently, keep on forming bone. Osteoclast sometimes keep on resorbing bone. They never function in sync. The asynchrony is the problem in Paget's. That's all. Why there's asynchrony? There are a few causes, definitely. I do have sporadic causes. There is virus. We found paramyxoviridae, measles virus in the Paget's disease bone, the RNA. So we said that, okay, measles could be one of the reasons. We are not yet sure. That's one of the reasons. But we have genetic mutation. Remember them. SQSTM1 is a very common mutation seen in close to 50% of hereditary Paget's. What they do is they increase the nuclear function beta. So it increases the osteoclast activity like anything. So normally osteoclast resorbs the bone, osteoblast should lay the bone. Because of this mutation, osteoclast will not stop. It will keep on removing the bone uncontrollably. That's one problem here, right? Then same, rank mutation, activating mutation of rank, the receptor, and the inactivating mutation of osteoprotegerine. Again, this will tilt the balance between the osteoclastic and the osteoblastic activity, right? These are etiology and genetics. So what will happen if there's a tilt? There are three phases in pages. Can anyone tell me the phase of pages? The first phase is the intense osteolytic phase. Remember SQST-M1 mutation? Intense osteolysis phase, completely osteolytic, right? So there'll be a massive overactivation of osteoclasts. Everything will remove. In this phase, if you take a biopsy, you might see osteoclasts with up to 100 nuclei, very active osteoclasts. So what will happen? Primarily, bone will become very thin. The patient might experience a little bit of pain because of thin bone, thin cortex, right? So over the period of time, I'll have both acting in synchrony. This is an intermediate stage where it looks like the symptoms have removed, the symptoms have gone because lysis is there, sclerosis is there, more or less same, right? So we have mixed response here, both resorption and absorption, right? But again, not in sync. Both happens, but not in sync like a normal bone. The third stage is an burnt out stage, which is osteosclerotic stage. Here, predominantly osteoblastic activity. You'll have mosaic bone pattern of bone, an MCQ, a Viva question. I would expect this in an answer. What does mosaic bone mean? Normal bone la cortex, medulla, bone marrow spaces. But here, let's assume this is the bone. You'll have only bony part. There'll be no bone marrow space. Like a mosaic, they'll be perfectly attached without any gap in between. That we call it a mosaic bone pattern. Bony trabeculae fuse irregularly in a jigsaw-like fashion. There is no bone marrow space at all. That's what mosaic bone pattern is, right? This is important. Remember this because this is what gives us the history. The bone is very thick, dense and sclerotic. Doesn't mean they are strong. They're thick doesn't mean they're strong. Chalk piece is thick. It's very dense. They're not strong. You hit a chalk piece, it will break. Fine? Okay? Fine. Next. Now, what will be symptoms of bones? Page's disease. Page's has multiple symptoms. Pathological fracture is one of the classical example because I have a thick bone doesn't mean they are strong bones, right? That's one. Okay? You can have pathological fractures because they are thick but not strong bone, right? Next, skin involvement. Pages can be monoosteotic, pages can be polyosteotic. Fine? Leonine facies, see, entire flat bone becomes thick. Imagine the brow is going to become very thick, zygoma is going to become very thick, jaw is going to become very thick. Leonine facies, like a lion. Okay, leonine facies, heart size increases. Increasing in heart size, symptom for two disease. One is Paget's, other is acromegaly. Head keeps on growing. Normally, head doesn't grow beyond a certain age group, but here it keeps on growing, right? And because the head is so heavy because of the growth, patient love drooping of head. Head will droop. Head drooping, increased heart size and leonine phase, classical. Very important neurological and hematological. Because skeletal you'll remember. Neurological and hematological we don't remember. There's no bone marrow space. So you'll definitely have cytopenias. It's not that bone marrow is not functioning. There's no space for it to function. Okay. Then neurological. Here what will happen? Cranial nerve palsies. Because if you remember anatomy, every nerve comes out of an orifice, right? You remember that. You also have the foramen with mnemonics and all, right? So every lumen now becomes smaller because the bone becomes thicker and thicker and thicker and thicker. So they'll have compression. Multiple cranial nerve palsies, cytopenias with broken fractures and a heavy head with a drooping of head. Diagnostic of Pages. Like I said, I can have involve one bone or I can be multi-osteotic. So how do I diagnose? Yes, symptomatic diagnosis is one. I take a biopsy. I see the burnt out phases. There are few markers for bone absorption, resorption that also can help in Pages. An X-ray can find the osteosclerotic stage of Pages also, right? Okay. Two complications must to remember. Pratima, first of all, osteoporosis, that's not the primary way of treatment, right? We have multiple things. Along with that, we have given injections to maintain the hormonal balance. That's all. Fine. Okay. Let's come back to this. High output cardiac failure is one of the complications. What happens in why there's a high output cardiac failure is one bone is forming, resorbing. It needs a particular blood supply. Imagine 20, 30 bones in the body is hyperfunctional. When it's hyperfunctional 20, 30 bones, automatically what it will do? Everything will consume blood supply. So the heart has to compensate for that. So heart keeps on pumping more and more and more. So that results in high output cardiac failure. More vascularity plus the patient will have anemia because of cytopenias. There's an increased cardiac output. Heart fails beyond a certain point of time. What will happen? Fine. Okay. Fine. Now, secondary osteosarcoma. Secondary osteosarcoma is also one of the complications of Pages. So here, because of the turnover, the bone environment, lots of inflammatory cells will be there, because when there's a high turnover, inflammatory cells will definitely be there. That will definitely cause mutations which can convert them into osteosarcoma. Important for the reason that normal osteosarcomas happen in first or second decade of life. That's a primary one. Secondary osteosarcomas happen around fifth or sixth decade of life, which can be secondary to Page's disease or which can be secondary to your radiation. Normal primary happens in the first and second decade of life only. Fine. That's in short about Page's disease. Okay. Fine. Okay. Someone asked me about a long answer for an osteosarcoma. Okay. I'll answer that. So bone tumors, honestly, for an undergraduate, I will not ask bone tumor as a long answer. Maybe I'll ask the classification of bone tumor as 2-3 marks. Then about a single bone tumor for 2-3 marks. And I'll give you a history, diagnosis, why this bone tumor is 2-3 marks for diagnosis. Fine. Okay. This is there in the metadata. Please go and have a look at it. Coming, Sajiv, coming. See, osteosarcoma alone, talk note on osteosarcoma as a long answer. It's very difficult for an undergraduate to write. Even if you write the entire Robbins, might not be enough. But there are easy ways where I can structure any bone tumor with the classification, with the diagnosis, and we'll talk about osteosarcoma also. Fine. Okay. Yes, Sajiv. You will the same parts will have also classification 2 marks of the bone tumors, osteosarcoma 2 marks, complications 2 marks, something split like that, right? I'll talk about that soon. Now, if you have to classify bone tumors, we have tumors which form bone, tumors which form cartilage. Hematopoietic tumors also can be there in bone. Myeloma, presence as bone, right? Multiple bony lytic lesions, classical for myeloma. Tumors which does not know what is the origin from, right? Okay, like giant cell tumor, Ewing sarcoma. They are from primitive cells, which can happen. Fine. And neuroectodermal derivatives. We know that for a fact that midline of the bone has some buried neuroectoderma inside them. From there also I can have tumor, which also primarily presents as bone, right? Bone forming tumors, osteosarcoma, that's the most common primary bone forming tumor. Osteomas, osteoblastoma, osteoblastoma. I'm putting a mark there because both of them are same. The only difference is location and the size. Radiology, gross microscopy of osteoblastoma and osteoblastoma is more or less the same. Fine. Cartilage forming tumors. Whenever the term chondroma is there, it's cartilage forming, right? So you can have osteochondroma, bone and cartilage. This is the other name for exostosis. And enchondroma, which is there in between, inside the entire bone, I have a encapsulated cartilage formation. It's enchondroma, right? Chondroblastoma. It's an immature tumor with small round blue cells. Then obviously I have the malignant guy, chondrosarcoma. Just give me a second. Okay, chondrosarcoma. Hematolymphoid tumors, myeloma as well as lymphoma. Hodgkin's lymphoma, which can go to the bone marrow, which can also involve the bone. Multiple myeloma is then the bone marrow, which can definitely erode the bone and form into the bone, right? Unknown origin, benign giant cell tumor, malignant Ewing sarcoma. These are undifferentiated tumors. It's not like I don't know what it is. We just put them as mesenchymal origin, undifferentiated cell tumors, right? And giant cell tumor is a benign tumor, locally aggressive, but still a benign tumor, fine? Neuroectodermal chordoma. Chordoma can come as a 2-mark question. Chordoma is coming from the neuroectodermal tumor. I can have in the sacrococcygeal region or cleavus, where there is excess neuroectoderm buried inside the bone. Okay. What I see in microscope is this cell can come as an MCQ. Physalliferous cell. The cells will be huge cells with abundant bubbly cytoplasm. Looks like mucin filled cells, which can be a differential diagnosis for mucin secreting carcinoma metastasis as well. Fine. Okay. It's okay, Pratima, you'll do well. Don't worry. That's about chordoma. Just remember the malignancy, neuroectodermal. It's not benign. Please remember, chordoma is malignant, right? A malignant tumor originating from neuroectoderm, seen in the midline of the bone, and you see physalliferous cell. Fine. Okay. Done. Then the bone forming tumors. Osteoblastoma and osteoblastomas. Like I said, both are same. The only difference is the size. Less than 2 cm, we call it osteoblastoma. More than 2 cm, I call it osteoblastoma. And the location. Osteoblastoma is generally seen in the appendicular skeleton, axial skeleton. Osteoblastoma is generally seen in the appendicular skeleton. I see in the spine, generally in osteoblastoma. I see in the limbs, generally in osteoblastoma. Fine. Here, this will be in the history. When you go to orthopedics, this will be the classical history which will be presented. Severe nocturnal pain, which will be relieved by aspirin or simple NSAID, classical. I can also have a reasoning by question. Why is there pain which is in the night and which is relieved by NSAIDs? Answer is simple. The proliferating osteoblasts produce prostaglandins because they are tumors which will have more prostaglandins. Prostaglandin by default will cause pain, and the moment I give NSAID, the prostaglandin production reduces. That's why there's a dramatic relief in pain. Why at night? Because at night is where the circulation becomes reduced. The prostaglandin stays locally for quite some time. Otherwise, I'm walking and running. Prostaglandin is there, it's washed away and it's gone into the blood circulation. Here, I don't move it, accumulates over a period of time, causes pain. This is the reason why nocturnal pain and why it's relieved by prostaglandin, right? X-ray, I have nidus. Nidus is a classical finding. Just write the term nidus. That should be more than enough. What I see in microscopy, I see active bone formation in the center, surrounded by fibroblastic tissue. That's enough. It's an osteoid tumor, bone forming tumor. That's all. Fine. Let's come to osteosarcoma. What I'll write? See, osteosarcoma first, most common malignant bone tumor. You can write that point. Second, the types. I have, based on the etiology, I divide them into primary osteosarcoma, secondary osteosarcoma. Where primary happens? It happens in people in first and second decade of life. Secondary happens in people in fifth and sixth decade of life. Post-Paget's, post-radiation. You know for a fact, you can write it for a fact. Radiation causes mutation, and due to some other cancer, this can be a secondary tumor by default, right? Genetics. Please do write these both genes without fail. Retinoblastoma is one of the classical mutation and also TP53. Okay, great, good day. Also write this. See, pathogenesis of osteosarcoma, chromothripsis, you can easily write for 2-3 lines or you can shrink it to 1 line. Chromothripsis is a very random event, carcinogenic event. What happens in chromothripsis, and this is seen only in osteosarcoma, a random carcinogenic event kind of breaks all the 46 chromosomes inside a cell, right? That's not seen generally. All the 46 chromosomes break and they reunite randomly. For example, I draw 2 chromosomes here. Let's use a different color. And let's say these 2 chromosomes break and it reunites with this. And the other part reunites with this. This is a single translocation, right? This is single translocation. But imagine 46 chromosomes breaking and joining in 46 different parts, which is going to result in multiple activation of proto-oncogenes and multiple deletion of tumor suppressor genes. That creates a very, very highly aggressive tumor, which results in poor prognosis, right? These two, you can easily write for half a page. If possible, draw diagrams having 4 or 5 chromosomes, breaking and rejoining. That's classical, seen only in osteosarcoma. That's one, right? Second, history. Whenever history comes for any bone tumor, look at the location. The most common location for osteosarcoma and most of the bone forming tumor is lower end of femur, upper end of tibia. It generally presents the mass, that's all. A bulge in the lower of tibia, upper end of tibia, or a pathological fracture, because cancer can soften the bone, you can have a pathological fracture, right? That's how the patient will present with most likely, right? How do I diagnose? Diagnosis of any bone cancer does not start with biopsy. It's always with radiology. Radiology, 2 findings which should be there is Codman's triangle and your sunburst appearance. Okay. Please, if it's a long answer question, explain what is a Codman's triangle. Why do I have a Codman's triangle, right? Codman's triangle is nothing but let's say there's a bone. Okay. There's a periosteal elevation here. So, in case of an aggressive bone tumor, they will elevate the periosteum. So, it's not only for osteosarcoma. Any aggressive bone tumor will elevate the periosteum. That gives a shadow which looks like a triangle. That's called a Codman's triangle. Fine. Okay, that's one. Second is sunburst appearance or sunburst calcification. These are bone forming tumors. When the tumor goes from the bone to soft tissue, tell me, Ayush, which is hard? Obviously, soft tissue will have calcification. So when I take an X-ray, I'll have calcification in the soft tissue outside the bone as well, which looks like a sun rays or a sunburst. We call it sunburst calcification. Explain why it is seen if it's a long answer. Otherwise, just name them Codman's triangle, sunburst appearance for a short answer, right? Then I take a biopsy. Biopsy is not diagnostic. Sorry, biopsy is, it's always diagnosed with the help of radiology. Biopsy alone is not diagnostic, right? First, in biopsy, one of the most important finding what I look for is, I look for malignant osteoid formation, and you'll have very, very ugly looking cells, right? One, you'll have extremely pleomorphic cells. You might have Jane cells. When I say Jane cells, I'm not talking about the multinucleation one, large big cells. Then malignant osteoid. This word has to be there. What is malignant osteoid? Generally, if you remember a bone is formed by a rim of osteoblast. Multiple osteoblasts will be there to form a single bone. One osteoblast cannot form a bone, right? But here you will see a bone devoid of osteoblastic rimming, which means this bone is not formed by multiple osteoblasts. It's formed by one guy who's malignant, who's growing like crazy. So if you see a bone without osteoblast, it's definitely abnormal. Fine. Extremely pleomorphic cells and malignant osteoid is diagnostic of osteosarcoma, but I will correlate with your radiology at any go, right? Now, if required, write IHC. Generally, I don't go for an IHC. SAT B2 is a good IHC. Positive of MDM. MDM1, especially with respect to the mutation analysis, retinoblastoma and the P53 mutation cause the MD1 positivity. That also is a good diagnosis, right? Treatment. See, when it comes as a long answer, don't stop with pathology. You know a little bit of surgery. Treatment has to be amputation. So obviously in treatment, right? Chemo plus surgery. If you want right surgery, right amputation. Again, it can metastasize. It's a sarcoma. Can anyone tell me where it can spread? Sarcoma generally spreads to the hematogenous route. It can go to the lungs. Lungs is the most common set of metastasis. Or it can go to the brain, or it can go to the liver, where it can definitely metastasize, right? That's in short about osteosarcoma. See, Sajeev, writing a theory paper, think, structure, write. I know types. I know a little bit of etiopathogenesis mutation. I know heading for clinical feature. 2-3 points for radiology. 2-3 points for microscopy. 2 points for IHC, 1 point for metastasis, and 1 point for chemotherapy, which easily gives you 10-15 solid pointers. All these are important pointers. If you write this, that's more than enough, right? Robbins has content to be written for almost every question. It's very condensed, that's all. The same way this slide is. But if you expand it and write it, you can definitely write an exam, fine? That's about osteosarcoma. I'll go quickly with exostosis. Might not come in a short answer, but exostosis, this part where a tiny bit of bone grows outside from the epiphyseal-metaphyseal junction. Okay, it's a most common benign tumor. Okay, and exactly the growth plate at epiphyseal-metaphyseal junction. So you'll have a cartilaginous cap here. It's not just the bone; it's a cartilaginous cap. That's why we call them osteochondroma. It's osteo plus chondroma. Osteochondroma. I have EXT1, EXT2 gene. The most important thing from here is the cartilage cap thickness. The cartilage cap is more than 2 to 2.5 centimeter. I'm always worried because it can become a chondrosarcoma. Do remember them, right? And for chondroblastoma, only one thing which I want you to remember is the microscope. It is a classical chicken wire calcification, can come in a viva or an MCQ, right? Blastoma, small round blue cells with chicken wire classification is very, very classical, right? Ewing's can come as short note. GCD can come as short note. We'll read a little bit in detail, right? Ewing's origin, I don't know. Mesenchymal stem cell, undifferentiated tumor. The latest name for Ewing's is not even Ewing's. It's undifferentiated sarcoma is the latest name for Ewing sarcoma. I don't report them as Ewing's. Ewing's location is diaphysis. Genetics is must for Ewing's. Both the translocation should be there. Because if I'm doubting if the Ewing's or not, I do a FISH to diagnose that with the help of translocation, right? 1122 and 2122, what is important is EWS gene. Ewing sarcoma is EWS. That's a gene which is getting translocated to FLI1 or ERG gene. Because it's translocation, I'm going to have activation of the transcription factors, and that is going to cause uncontrolled proliferation and lab cell division. That's what causes Ewing sarcoma. Radiology of Ewing's, we have an onion skinning appearance. You'll have a little bit of, this is not an exact good radiology. You'll have peels like it, onion peel appearance or onion skin appearance, the classical finding of Ewing sarcoma. When you go to orthopedics, the teacher will tell you more in detail on how to examine that, right? Microscopy is important. Ewing sarcoma is a small round blue cell tumor. Multiple small round blue cells, very less cytoplasm, and some of the cytoplasm will have glycogen content in it. The moment you write glycogen content, you automatically have to write, yes, these cells are PAS positive because of the glycogen content. Ewing's is a small round blue cell tumor. Can I say, I want you guys to answer in this, can I say they might have rosettes? Yes, no, maybe. Is there a possibility that they might have rosettes? Yes, they'll definitely have rosettes, right? They'll definitely have rosettes, right? So they'll have pseudo rosettes. Perivascular pseudo rosettes are common, okay? Are seen in Ewing sarcoma. Sometimes Very rarely, you can also see hemorrhoid type of rosacea as well, but perivascular pseudorosacea is something which is common in case of an Ewing sarcoma, right? So I know the etiology, little bit of mutation, microscopy, pathogenesis, radiology, and history is same. First to second decade is a common stage, a bony swelling, that's how the patient is going to present with. IHC markers is important. These two are very important. It's not FLY, it's FLI1. FLY1 and NKX 2.2. These are the latest and the best markers available. CD99 was used, I don't use it anymore, right? Treatment, again, chemo plus surgery is a treatment for Ewing sarcoma. Fine, okay, that's about Ewing's. Let's come to GCT. GCT is again a tumor which does not have a classical origin, undifferentiated cells, mesenchymal stem cells. GCT is a benign tumor, but I do have malignant counterpart as well. But they are benign, very, very locally aggressive. Fine. So average is 20 to 40 years. Important because osteosarcoma, Ewing sarcoma, most of them are seen in first and second decade. This is seen from second to fourth decade. You might miss it. Location is very characteristic. All the 3 points are required. Epiphyseal tumor. Most of the tumors are in diaphysis and few in metaphysis, but this is classically in epiphysis. Eccentric tumor and expansile tumor. All three are classical for giant cell tumors. Radiology, it exactly looks like this. Why does it look like it? It's osteoclastoma. So many osteoclasts are there here. Uniform osteoclasts. So they will scoop out the bone completely, leaving a thin rim of septum that looks like a soap bubble on X-ray called a soap bubble lesion. Very thin rim of septa is there and the entire tumor will destroy the bone. Fine. By the way, osteoclastoma or giant cell tumor is a misnomer or not? I want you guys to answer on that, right? What you see in microscopy is, I'll see giant cells which are not neoplastic, which are reactive, which makes the tumor name a misnomer. It's not a tumor from osteoclast. It's an mesenchymal stem cell related unknown origin tumor. We don't know the exact origin as of now, but it's not coming from osteoclast. What giant cells I see are reactive osteoclastic giant cells. So who are the stromal cells? The cells which you see outside the giant cells, the mononuclear cells, they are the stromal cells, they are the neoplastic cells. Giant cells are not the neoplastic cells, do remember them, right? Treatment here, more or less curate the entire part and replace it with a bone cement. That's how it is. Or if it's involving the joint space, you resect the thing and give an implant, right? I don't require chemotherapy for this because not that of an aggressive tumor, not of a malignant tumor, right? Okay, that's about the bone tumors. Yes, you can have a classification. Remember the classification, and maybe osteosarcoma or one of the tumors can be asked as an essay. Fine. Okay, perfect. Let's go to the next guy. Next is your CNS tumor lesions. Was any tumor in CNS asked in your universities? CNS, they generally don't ask because not an easy topic to learn and understand. If they ask, they might ask maybe meningioma, because meningioma is something which we least expect you to know, and maybe glioblastoma because of the most aggressive nature. Again, CNS tumors, if it comes in an essay, it's going to be with classification, that's all. How do I classify tumors? Raviraj, I know that CSF examination, I think micro ma'am must have taken CSF examination. I have not included the CSF examination here for that primary reason. Okay, I have included only the CNS tumors. Write the classification. Just look at the origin, astrocytic origin, meningeal origin, posterior fossa origin, and your ependymal origin and neural origin for schwannoma. Just superficially, fine. And few words about the CNS tumors. Can come in one-liner or one-mark question. Glioblastoma, grade 4 tumor, the most aggressive tumor. It can spread via the corpus callosum to the next hemisphere, looking like a butterfly. So we call it a butterfly tumor. Important thing is an MCQ, do remember them. I have two types of glioblastoma. One, de novo, originating from normal brain, which is wild type. Wild type is non-mutated, right? I have one tumor of in skin, mole and melanoma. I'll talk about that. Okay. And secondary is coming from pre-existing glioma, which has IDH mutation. IDH mutation is classical for glioblastoma. Do remember them, right? So what I see in microscopy is, I see irregular serpiginous necrosis and pseudopalisading. I have necrosis here. Surrounding that, I'll have glial cells which will be palisading. That's a pseudopalisading necrosis. This is classical for your glioblastoma. Yes, inside. Just few words. I'll complete it. Then we'll go to the mole and melanoma. We'll look into that. Fine. Oligodendroglioma, again, 1p19q co-deletion, very classical. And the fried egg appearance with lots of tiny capillaries called chicken-wire capillaries, which is diagnostic for oligodendroglioma. And a very important clue. A CNS tumor presenting with seizures, fits, is oligodendroglioma without doubt, because that's one tumor which can present with fits. Fine. Next, about the posterior fossa tumor. In the cerebellum, yes, Raviraj. In the cerebellum, we have two tumors. One is pituitary, pilocytic astrocytoma. The other one is medulloblastoma. Right? One is grade 1, one is grade 4. Pilocytic, solid and cystic. This is an extremely solid infiltrative mass, your medulloblastomas. Fine. You have rosenthal fibers. This can come in a 1 mark, which is nothing but GFAP extension, glial fibrillary acid protein. Right? And you have cells which can have extension like this, a bipolar cell. And here you'll have an elongated cell. It's a medulloblastoma, right? Rather than small round blue cells, I'll have an elongated cell which has a carrot-shaped nuclei. Medulloblastoma can have homoerite rosettes. Rosettes are not there in pilocytic astrocytoma. This is a glial tumor, so GFAP positive. Neuronal tumor, so synaptophysin positive. Meningioma can definitely come in a short note or in a viva question, because you might have samples of meningioma also if your hospital has that, right? Arise from leptomeninges. Remember this, common in females, and it grows during pregnancy. Any tumor which grows during pregnancy, one of them is meningioma, because they are progesterone receptors in them, and they are associated with NF2. Two classical findings in microscopy: whorls and samoma bodies. These are Vimentin positive and they're also GFAP negative. Fine. Okay. One word about SEGA. SEGA, it's an astrocytoma, subependymal giant cell astrocytoma. The only thing I want to remember is it is classically associated with tuberous sclerosis part. Fine. Last but not least, schwannoma. Schwannoma, Antony A, Antony B pattern, Verroque bodies. These can come in one-liners. Do remember, whenever you see these two patterns, Antony is hypercellular, Antony is hypocellular. In that hypocellular area, I have palisaded nucleus of Schwann cells, which you call as a Verroque body, which is diagnostic. Schwannoma, acoustic neuroma, a tumor presenting in CNS with tinnitus. You'll read in ENT as well. Both schwannoma and acoustic neuroma are same. Both are SN positive. Fine. Okay. That's in short about CNS. Let's go to skin. I have not talked about the basal cell carcinoma or squamous cell carcinoma. Squamous cell carcinoma is very simple. Basal cell carcinoma is only one mutation, past mutation. I'm sure you'll be able to write it. Fine. In BCC, maybe after completing mole, I'll talk about BCC. Right? In skin, we divide tumors into pigment forming tumors, non-pigment forming tumors. In pigment forming, I have mole and melanoma, benign and malignant. In non-pigment forming, I have basal cell carcinoma and squamous cell carcinoma. Right. First, nevus or mole. Whatever you see in your body, whatever we have is nevus. Nevus is singular, nevi is plural. They are all benign tumors of melanocytes. The mutation and the pathogenesis is very unique here. Mole have a mutation called RAS mutation, which you all know. Generally, we think that the moment I have RAS mutation, which will end up in having a cancer. That's what is different here. There is a mutation. The melanocytes keeps on dividing. After a point of time, they have something called an RAS-induced senescence. The mutation itself has an auto cutoff. We don't know why, but this happens. The auto cutoff, what it does is, it destroys the parent cell. Whichever was proliferating, it destroys. So the daughter cells cannot progress. They'll stop. The growth will arrest and the cluster alone remains. I don't have any new cells. So a lesion becomes big, produces a black color, remains as such. That is mole or your nevus pathogenesis. RAS induced senescence, which is auto destruction of the parent cells. So the daughter cells just accumulate there and they stop there. That's all, right? So what happens in mole or nevi is, nevi has multiple types. If I have the excess growth, only the junction, that is epidermal junction, we call it junctional nevus. If you have in the epidermis and also inside the dermis, we call it compound nevus. We have a raised papule, have both junctional and dermal component. Sometimes this epidermal component must have been gone. Everything will go down into the dermis. That's intradermal nevi. Okay. The most important thing is intradermal nevi, the pigments are so deep, I won't have anything on the top. Fine. Okay. I'll discuss them, Ravi, for sure. Fine. So this nevus and this transformation to epidermis, and we call something as a neurotization. That's classical for intradermal nevus, right? If you have pigments changing to nerve fibers, that means I'm talking about a benign condition, right? Nevus cells, markers, they are ascended, HMB45, both are specific and sensitive. For melanoma, it will be pleomorphic. For nevus, there will be normal nevus cells. They also have a very prominent nucleoli, right? For melanoma, melanoma can happen de novo or melanoma can happen from a pre-existing nevus mole to melanoma sequence. Obviously, the most important thing is UV exposure. Intense amount of UV exposure, like sunbathing, intermittent but intense amount of UV exposure is one of the important causes. Fair skinned people definitely have more risk of mutation because melanin is a UV protector and genetic syndromes like xerodermas. BRAF mutation, P16. These are two most common things required. It starts with same RAS induced senescence, stops there, but BRAF takes an upper hand. P16, the tumor suppressor gene gets mutated, so it starts growing a little bit, becomes a dysplastic nevus. When telomerase attrition happens, it becomes immortal and becomes metastasized. BRAF is important for melanoma. You have to know about it because of the targeted therapy which is available for BRAF. In melanoma, I have two types of growth phases: horizontal radial growth phase or a vertical growth phase. Radial growth phase, the tumors grow mostly towards the surface. Superficial spreading, lentigo malignant, acral lentiginous. These are the subtypes of melanoma, have predominantly radial growth phase. When it grows deep, vertical, into the dermis, obviously you'll have desmoplastic reaction. So more desmoplasia, more fibrosis, more hard the tissue becomes. So I have a nodular melanoma here. Types of melanoma only, nodular melanoma, right? And this features ABCD helps me to differentiate where is a mole of melanoma. If it's asymmetrical, okay, and the borders are not so regular, it's irregular borders. There's a difference in the color variation, or it has grown. Previously it was here, it has grown beyond 6 millimeter. Growth beyond 6 millimeter is something which is not important. If it's important for me, if it's not normal, it has to be neoplastic, or it evolves from a mole to a melanoma, becoming irregular and everything. We think of a melanoma, its clinical danger signs or ABCDE criteria, right? And for prognostic factors, we use TNM staging now, but previously we had Breslow thickness, which measures the depth of invasion. This is what TNM does now. And we have something called Clark staging. Again, the depth only, but based on the histology. Only in epidermis, only in papillary dermis, only in reticular dermis. Again, more deeper it is, more worse it is. These are very important: tumor aggression and tumor infiltrating lymphocytes. Melanoma is one tumor which can undergo spontaneous regression. It can disappear because sometimes the human lymphocytes are so aggressive, identifies the melanoma cells and completely destroys them. This is where immunotherapy started, because when my lymphocytes can normally destroy melanoma, why can't I make them destroy every other cancer, right? So aggressive tumor infiltrating lymphocytes and tumor regression happens, they are all both a better prognostic sign, fine. And generally an extremity melanoma has a better prognosis compared to the melanoma the head and neck on the trunk, fine. This is in short about melanoma. You want about the basal cell carcinoma, squamous cell carcinoma, I'll talk about them as well, fine. See, BCC, you know the origin, it's going to come from the basal cells, right? One of the most important thing which they will ask when they come to BCCs, it's one of the malignancy which hardly undergoes metastasis. Do remember them, never forget them, right? BCC never metastasizes or rarely undergoes metastasis, right? Where is BCC? It's one of the most common skin cancer, right? It's a very slow growing cancer, never spreads. The location of BCC, majority of the location of BCC is in the sun exposed areas. Sun exposure is one of the most common areas, most common trigger for BCC. So it happens in sun exposure areas, right? Classically, it happens in something called a tear zone. It's above the, if I have to, when you cry, the tear flows in this area, right? That's a place where BCC is very common, in the cheeks, in the nose area, exactly in the tear zone, right? The location is in the head and neck, most common, and especially in the tear zone. That's where BCC is more common, right? If you look at the gross appearance of BCC, they are generally nodular. And the most important thing, at the base of the nodule, if you have a nodule like this, at the base of the nodule, you'll see telangiectatic vessels, dilated vessels. That's very, very classical for BCC. Dilated vessels at the base and nodules are very classical for BCC. Sometimes they can also be ulcerated. There's one more name for BCC. Because of the appearance, they also call them a rodent ulcer. Okay, rodent ulcer is the name, other name given for BCC, because if it's untreated, it becomes extremely ulcerative and locally destructive. Looks like a rodent bite, we call it rodent ulcer. Fine. Okay. Now coming to the pathogenesis. BCC again has same like your any other cancer. I have sporadic causes. Sporadic causes by default is UV rays, UVB. You know how UV rays causes cancer. UV causes pyrimidine dimers. Pyrimidine dimers untreated is going to cause lots of mutation which causes cancer, right? BCC can also be syndromic. There are multiple syndromes which causes BCC. Some syndromes causes every skin cancer. For example, Lee-Fraumeni. Leaf Romney is p53 loss. Every skin cancer can be there. Squamous cell carcinoma, basal cell carcinoma, as well as melanoma. Right? Same with xeroderma pigmentosa. It increases risk of skin cancer, that's all. In xeroderma pigmentosa, we have a problem in your nucleotide excision repair. Again, it increases risk of almost every cancer. But particularly for BCC, I want you to remember one syndrome, which is nevoid basal cell carcinoma syndrome or Gorlin syndrome. Okay, Gorlin is seen classically in BCC or nevoid basal cell carcinoma syndrome. Fine, that's Gorlin syndrome. So Gorlin syndrome, what happens is I have a mutation in a pathway called as sonic hedgehog pathway. SHH pathway can be seen in sporadic BCC, but also in syndromic in Gorlin's related BCC, right? So the pathogens of Gorlin syndrome, a pathway is SHH pathway, which is sonic hedgehog pathway. Okay. So we'll see what happens normally and we'll see what happens in mutation. In a normal sonic hedgehog pathway, there is a gene called as PTCH, patch gene, and this gene called as smoothened, SMO, right? So this PTCH protein binds with smoothened and inactivates it. Only when the growth factor comes, PTCH goes away, smoothened activates, does the job, right? So in a normal thing, I have two proteins here. The dark one, let's say it is the SMO or the smoothened. This is PTCH. So this is normal, they will bind, and the moment PTCH bind to the smoothened, it becomes inactive. So only when this receptor or the growth factor binding to the receptor, the growth is required. This growth factor binding will destroy the patch and then smoothen gets activated. Only when the growth factor binds, the smoothen gets activated. Once the smoothen gets activated, it will cause a transcription factor, it will cause cell division. That is normal. Fine. So now what happens in SHH mutation or the sonic hedgehog? This entire pathway is sonic hedgehog. So what happens in the mutation in the BCC sequences? You will have a loss of function mutation PTCH gene. Again, this is seen in both sporadic as well as syndromic. It is called as patch gene or PTCH gene. The moment I have loss of function mutation, what happens? SMO is auto-activated, even in the absence of growth factor. The moment they are auto-activated, it causes uncontrolled growth. When there's uncontrolled growth, automatically you're going to end up in having cancer formation. As simple as that. Got it? In Gorlin syndrome, apart from having basal cell carcinoma, your tumor also they'll have CNS tumor, because this pathway is also involved in the CNS. They also might have medulloblastomas, right? Nevoid basal carcinoma, obviously have BCC. There's also CNS tumors like medulloblastoma, where also SHS is a very common pathogenesis, fine. And also some of the hepatic adenoma also, SHS pathways involved, fine. That's about nevoid basal carcinomas or basal cell carcinoma pathogenesis, fine. We know the clinical history, we know the location, we know the pathogenesis. So what do we do in gross? And gross also we know microscopy. Microscopy, these are primarily dermal lesions, right? The first finding, if you can draw a diagram, draw an epidermis, you will see nests of tumor cells in the dermis. That's very important. It's a nesting pattern in dermis. And it's made of basal cells. Basal cells are extremely blue, high NC ratio cells. Normal basal cells are blue and high NC ratio, right? So how do I identify them or differentiate from others? One, you will have lots of small round blue cells here, basal cells. The most important thing is the corner. The cells in the periphery of the nest will have palisaded appearance. That's very important. It's peripheral palisaded nuclei. Center will not have palisading. It will be normal like a mix. The periphery will be perfectly palisaded. That's one classical finding. The second classical finding is that this nest is there in dermis. Dermis is purely made of collagen, right? Let's assume dermis is made of collagen. The thing is, there'll be a tiny area or gap between the nest of tumor cells and the collagen. They won't merge. That's called a retraction artifact. This is very, very classical. There'll be a space, a retraction space between the nest of tumor cells and the dermis, which is very classical for basal cell carcinoma for diagnosis. We don't require markers to diagnose BCC. It's a very clear-cut microscopic diagnosis, that's more than enough, right? That's in short about BCC. Treatment is just surgical removal. Make sure the margins are negative so that they don't come back again. Recurrence is pretty common in BCC, but since they are cancers which don't spread a lot, they have a good prognosis, fine? Okay. Squamous cell carcinoma, you know the gross, pearly white ulcerative lesions. You know the microscopy, keratin pulse, same. Individual cell keratinization, invasion. You know the IHC, P40, P63, same thing. Etiological factors, yes, your sun rays is 1 by default. Same syndromes you can write. Xeroderma pigmentosa, you can write leaf romani. Premature aging syndromes, Verma syndromes also can happen, right? In addition to that, what is important for squamous cell carcinoma, which is not seen in others, is scars. Please remember them. SCC in pathogenesis, any chronic scars or burns. We have a type of ulcer causing Marjolin's ulcer. This word we'll expect it. Okay. That's important. At the same time, you can also have a lesion causing actinic keratosis. That's a precursor lesion for squamous cell carcinoma. This also due to UV rays only. Initially, it forms an actinic keratosis. Later on, automatically it goes to form a squamous cell carcinoma. Fine. Okay. That's it, Ravi. Squamous cell carcinoma. These are the etiology. Apart from that, look into the xeroderma pigmentosa, look into the leaf romani and Verma syndrome. Gross, same what we read in your lung cancer or esophageal cancer. Cauliflower-like ulceroproliferative growth, keratin pulse, individual cell keratinization, polygonal cells with abundant cytoplasm, IHC, same your P40 and P63. Fine. Okay. Gouts. What do you want in gouts? I know many things in gouts than given in books because I have gouty arthritis, right? Okay. Gouts. Sajeev, I have taken 2 sessions on slides for practicals there, which is there in your Meded YouTube channel. Just go and have a look at it, right? See, gout, we have predominant of the gout, 99% of the gout of metabolic of unknown cause, genetic of unknown cause, right? Gout is a metabolic disorder. Gout, I have genetic causes and I have sporadic causes also. Sporadic metabolic causes are important. We don't diagnose them, so we always think of Leishman syndrome. That's all. Leishman syndrome is very, very rare, not even significant for me, right? Sporadic metabolic causes, excess consumption of alcohol, excess consumption of meat. These are the 2 important triggers for having gouty arthritis because of the extremely high purine loads. That's all. Genetic causes, more than 99% of them are unknown. We don't know. My family has gouty arthritis. Close to 7 of my cousins are gouty arthritis. They yet to find what is the causative agent, right? But yes, it's pretty common in few clustered families. Yes, you also have the HGPRTase mutation, which you see in Leishman syndrome. That also is there, which is a known syndrome, self-mutilation along with hyperuricemia and gouty arthritis. Fine. Okay. Yes, inside. So what happens in gouty arthritis is I'm going to have excess amount of purine metabolite, that is uric acid. This uric acid goes and deposits into the joint space as sodium urate crystals. The pathogenesis. See, you can have a reasoning by question. I did answer to some of your friends also in the group. Why the first metatarsophalangeal joint and why in the early morning, right? So when the sodium urate crystals are there in the joint space, it is already there. Now also it's there. In the night also is there. In the morning also is there, right? Because of the periphery, why they prefer periphery is the temperature. There's a fall in temperature. This fall in temperature along with dehydration. When I say dehydration, I'm not talking about the dehydration of the person. It is negative only inside, not positive. If you have missed positive, positive is silica particles. Sodium urate crystals are negative by reference only. Fine. Dehydration in the joint space. Dehydration happens maximum in the joint space over the night towards the early morning, because I drink water in the night, I sleep over a period of 6-7 hours, I don't have anything. So that's the reason it's a crystal. It condenses more, right? So that will attract inflammation. It's a crystal which causes damage. Obviously, when the crystal causes damage, you'll have increased neutrophils coming inside. Neutrophils will try to remove the crystals. The fight happens. That's what results in the pathogenesis of gout, right? So gout presents with predominantly your first metatarsophalangeal joint pain, but it can involve almost every joint in the body. It involves almost every ligament in the body. Fine. Gouty arthritis can have pain, can have swollen joints, can have effusions in the joints. Worst case scenario, I can have tophaceous gout. Topha is white color condensed deposition of sodium urate crystals, which can be the skin or the joint space. That's the worst form of deposited crystals, right? Crystal is tiny, but if it forms a mass, that's tophaceous gout, fine? So what I see in microscopy, we don't do microscopy. It's a clinical diagnosis. Do a urology, blood examination, urate levels are more, sodium uric acid levels are more. We know it's gouty arthritis, that's all, fine? If you do an biopsy or microscopy, in the effusion fluid, what you'll see is, you will see needle-shaped crystals, okay? And you'll have inside, it'll be negative birefringence only. That's classical for gouty arthritis. Fine. Okay. Treatment of gout, you know, acute gout, I primarily look for the anti-inflammatories, colchicine. Chronic gout is about urate lowering drugs, your allopurinol, your febustat, and all those things, right? This is in short about gouty arthritis. Okay. Fine. Okay. Finally, I've completed your endocrine, CNS a little bit, and skin, whatever is required. Read well, give your exam well. Any questions which is not very specific to the point, which is a general question, think for some time and please go and have a look at that, right? Dr. MBBS, not sure, maybe in this or next month, right? All the very best, do well, hope to see you in the third year in flying colors after a distinction or honors, fine?